We're calling OIS now. Just give us a quick second.
Thank you so much. Welcome, Webster.
Hi, Madam Chair. We're having technical difficulties on the state side over here. We had to switch buildings because the health department building has a plumbing issue. So I don't know if you'll be able to see us on video. We're called in on the phone line.
Okay, we can hear you clearly.
Good.
So that's not a problem.
And Webster, I'll be controlling your slides, so just let me know when to advance.
Great.
And
okay.
We're live now, so we can get started.
Okay, wonderful. So good afternoon. Thank you for coming to the Health and Government Operations Committee. Today we're joined by the Appropriations Committee and members of two committees. We have a full agenda. Welcome to this Joint Government Operations and Health Facilities Subcommittee and Public Health and Minority Health Disparities Subcommittee briefing. My name is Jocelyn Peña-Melnick, and I am the Vice Chair of the committee, and will be joined, actually I'm co-sharing this today with my wonderful colleague, the Chair Rosenberg. This is a virtual subcommittee briefing, so I ask for your patience if we encounter any technological or streaming issues. Before we begin, I remind subcommittee members that this briefing is being streamed on the Maryland General Assembly YouTube channel. Subcommittee members will be muted throughout this briefing. If you have a question after each presentation, type question in all capital letters in the chat box on the right side of your window. I will call on the delegates to ask the question. Myself or Delegate Rosenberg will do that. After we call your name, please wait a moment while Melissa, raise your hand. And she's staffing our committee. And Tyler, she will unmute your screen. Members and participants also have the ability to unmute yourselves, but Melissa will do it. Remember, even though we're meeting on Zoom, please adhere to our usual committee rules of one question and one answer from the panel. We're gonna have a little flexibility today and allow for more than one question in some instances, but please don't make any statements, just ask the question and make sure that your question is shorter than the expected answer. For the first three panels, and we have four actually, of our briefing, we're joined by Chairman Resnick and the members of the Health and Human Services Subcommittee from the House Appropriations Committee. And they play a very important role and we work together. We welcome them and thank them for joining us today. And now to oversee the first portion of our briefing, I turn over the gavel to my wonderful subcommittee chairman, Sandy Rosenberg.
Thank you, my wonderful vice chair and other subcommittee chair for our second round of witnesses. Good afternoon, everyone. Today, as the vice chair has pointed out, Government Operations and Health Facilities and Public Health and Minority Health Disparities, our two subcommittees will receive briefings from a variety of departments and agencies regarding the impact of COVID-19 on Maryland. Each of the first three panels will be followed by a Q&A session. I will recognize HGO subcommittee members, and Chairman Resnick will do the same for members of his Appropriations Subcommittee on Health and Human Services. After the first three panels, I'll return to the gavel to the vice chair, who will oversee the fourth and final panel as chair of the Public Health and Minority Health Disparities Subcommittee. Our first panel will consist of updates from representatives of the Maryland Department of Health regarding procurement of COVID-19 tests and vaccine distribution. We'll hear from Webster Yee, Director of the Office of Governmental Affairs, Atif Chaudhry, I hope I pronounced that correctly, my apologies if I didn't, Acting Deputy Secretary of Operations, Brian Meraz, Acting Assistant Secretary of Public Health Services, and Mark Martin, Deputy Director of the Office of Minority Health and Health Disparities. Second panel, we will hear from Dr. William Moss, Executive Director of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. Dr. Moss will provide information regarding CDC's recommendations on COVID-19 vaccine distribution. As is the case with all presentations, it will be followed by a Q&A session. Our third and final panel will consist of Dr. Travis Gales, Health Officer for Montgomery County, who will provide updates related to local needs and outreach efforts for the vaccine distribution. Finally, our fourth panel will be chaired by, as I said, by Subcommittee Chair and Committee Vice Chair Peña-Melnick to deal with the Medical Cannabis Commission, at which time we'll hear from Will Tilburg, Executive Director of the Commission. Please keep in mind this briefing is scheduled to conclude by 4 o'clock. Chairman Resnick, do you have comments before we proceed?
Hi, thank you, Chair Rosenberg, Vice Chair Pena-Melnick. We're happy to participate on this briefing today. Just as a quick introduction, I am seeing Delegate Valentino Smith from my subcommittee, my vice chair, Delegate Mangione, and Delegate Michael Jackson, who is the vice chair of our Appropriations Committee and member of our subcommittee as well. I am not seeing the other members, so I think we will go ahead and proceed. Thank you for having us. Look forward to this. Thank you.
Very important issue, and we'll now begin. Mr. Yee, it is your panel.
All right, Webster, I have your slides on the screen.
Okay. Can you hear me now?
Yes, we can.
The infamous double mute strikes again. Good afternoon, Madam Vice Chair, Chairman Rosenberg, Chairman Resnick. Thank you for having us today. On behalf of the Maryland Department of Health, I'm joined by my colleagues Atif Chaudhry, Brian Morose, and Mark Martin. Secretary Schrader and Dr. Chan send their regards, and they're unable to be here today because at the exact same time they are briefing local elected leaders as well as the congressional delegation right afterwards on our vaccine distribution, the same presentation that you are going to be receiving in a few minutes. We apologize in advance for a slightly lengthy presentation. The two topics that the three subcommittees asked us to present on are very complex subjects, and without much ado, I'll get started. Next slide, please. The most important item that we would respectfully request everyone watching this video and all of the members on this committee, the three committees briefing today, do is to please, please, please implore your constituents and everyone to wear a mask, to practice physical distancing, to wash your hands, and if you were to get a call from the contact tracers, to answer the call and help us. And then, if possible, please get a flu shot. We're at about 24% of Maryland who have gotten flu shots this season. We implore every Marylander to get a flu shot now. Next slide, please. And if you could play the video. All right, next slide. Don't know if the video audio came through, but again, same message. Please just wear a mask and practice social distancing. Just brief updates on the Maryland Strong roadmap to recovery. We've now, as of today, conducted over 4.7 million PCR tests, and we're averaging about 35,000 PCR tests a day. With contact tracing, we've had over 100,000 cases and over 130,000 contacts that were reached and interviewed by the state's 1,400 and increasing contact tracers. We're proud to also say that 1.2 million Marylanders have now signed up for the exposure notification system with either their Apple or Google smartphones. And we beat California to the punch in getting this technology out. And according to Apple and Google, I believe that we're #1 in the country right now for exposure notification signups. So we thank every Marylander who has signed up, and we implore them, if you get a call, please pick up the phone and help us out. Next slide, please. In addition, and we'll discuss this more at length over the course of this briefing, we've distributed over 86 million pieces of PPE, and we're still getting requests from local health departments and other healthcare facilities. In addition, as the governor has noted in his recent press conferences, we have done, we believe, everything that we can now to work with our hospitals to make sure that any and every Marylander who needs a bed has a bed available. Next slide. Next slide. Many of you have asked us questions over the past couple of months about what is the health department doing. And we thought that we would give you a little bit more information about this is actually an entire state government response. Since the governor's proclamation of a state of emergency in early March, pretty much every executive agency have been working together and operating under it's called an incident command structure, ICS, that is facilitated through MEMA. And it's more commonly known and used in shorter term incidents like hurricane response or natural disasters or other sorts, but in this case, it also applies to the COVID-19 response. And it is important to note that this response has required some of the largest, most coordinated and sustained efforts in state government history. And it wouldn't be possible without the dedicated efforts of thousands of state employees who have worked for over 9 months without break, 7 days a week, to try to keep Marylanders safe. Next slide. A huge thank you. There are two components to the multi-agency coordination, which we'll call the MAC. There's a unified command structure, and then there's everyone else who's working. The unified command structure is composed of senior staff from the governor's office, MIMS, MEMA, MDH, and an alphabet soup of other folks. The health department is one of the lead agencies in support of this, and all of our staff are well integrated into this structure. Next slide, please. The Emergency Management Incident Command System is part of what the U.S. CDC has funded for the past 20 years. It's a basic preparedness. We have a very good set of folks who have been working over the years to make sure that the entire health department is ready to participate in this. And it's part of the National Incident Management System. Next slide. Again, more information about the system. If you have more questions, please go to the FEMA website to learn more. Next slide. It's important to note that the reason why we're operating under the incident command structure is because there are many agencies in Maryland state government, and every agency is uniquely suited to be better at certain things than other agencies. And so the entire point of the incident command system then is specific agencies with extra expertise or the abilities to make things happen are the ones who are the lead agencies. And this allows other agencies to specialize and focus on using their strengths to assist the entire effort. Next slide. As a basic example, these are just a representative sample of the Maryland state agencies that have been working in the MAC. And as you can see, this wouldn't be possible without pretty much every named state agency out there. Next slide, please. This is just a very, very high-level overview of the MAC structure. And again, it does not do justice to the thousands of people who are working every day to make this happen. Next slide. In particular, of focus to the three subcommittees today is the Finance and Administration section. Overall, there is a spending steering committee which approves spending for COVID-19 related goods and services. There's a procurement group, and it's important to note that at least as of right now, every procurement that we're discussing today is 100% federally funded. And as both the delegation, the congressional delegation, and the governor have been repeatedly asking since very early in the summer, it is very important for the federal government to get through an additional coronavirus relief bill. Next slide, please. Particularly key to this briefing today are the procurement protocols. The Health Department coordinates and continues to coordinate with the Department of General Services Office of State Procurement to manage the vast majority of the initial procurements and ongoing procurements related to the state's COVID-19 response. And in this particular case, DGS's Office of State Procurement operated as the procurement lead under the MAC. Next slide, please. And the basic reason is a more detailed form of what I told you earlier. The Health Department is not a specialized procurement agency. The Office of State Procurement is. They have additional procurement authority, and we couldn't have done this without their help. Next slide, please. And with this, I'm going to turn the laptop over to my colleague, Atif Chaudhry, Deputy Secretary of Operations.
Thank you, Webster. Again, apologies for the technical difficulties, and just wanted to, before we get started into this, I wanted to just recognize all the hardworking men and women that are part of the Unified Command. They've worked tirelessly around the clock to help the state prepare for and deal with COVID-19 pandemic. They've worked nights, weekends, holidays to ensure that the state is prepared to deal with this unprecedented public health emergency. Many of my colleagues in the room, as well as myself, we hadn't had days off since this pandemic began, just because of our dedication and commitment to making sure that the state is prepared. And you know, just to very quickly go through and to highlight what we've done. You know, we set up the additional hospital beds in advanced medical tents to ensure every Marylander in the state will have access to a hospital bed if they need one. We've acquired the PPE necessary for healthcare workers and vaccinators so they can care for patients. We've acquired ventilators to ensure that every Marylander that needs a ventilator will have access to one. We also set up testing sites and to exponentially expand our testing capabilities across the state, and develop comprehensive contact tracing capabilities to limit the spread of the virus. And we developed bridge teams for nursing homes to address outbreaks for our most vulnerable citizens. And coordinating the monoclonal antibody treatment for COVID-19 patients, and we're coordinating now, which is hotly in the news now, is the distribution and administration of the COVID-19 vaccinations and the vaccines that will be coming out. And this is directly attributable to the governor's leadership and direction of moving the state in the direction of preparedness and to respond to this, not necessarily for the short term, but for the long term. So I wanted to talk about our procurement challenges. I don't want to go into too much detail here, but I'm sure everyone was well aware of the significant issues associated with procuring an unprecedented level of PPE, medical equipment, and ventilators. Not only were we competing against other states, we're competing against other countries. So as Webster has indicated, the Unified Command had a procurement arm, so to speak, and logically speaking, due to the MDH's procurement restrictions with regard to procurement delegation, as well as MDH's lack of resources when it comes to our procurement department, we shifted all procurements over to the Department of General Services and the Office of State Procurement, which was better suited with additional support to handle all the procurements. And the federal government basically pushed out all the states to be on their own to purchase all of the necessary equipment. And testing resources were obviously in their infancy at the time and were rapidly evolving, and testing technologies continue to evolve over time. And there was an urgent need to test and perform contact tracing to really limit the spread of the virus. And that was really a big deal to ensure that we do not continue to spread the virus throughout the state. And Maryland had to ensure that we had sufficient hospital beds across the board. So next slide, please. So at the beginning of the pandemic, initially MDH, being the subject matter expert from a public health standpoint, determined the resources that were needed in order to that were going to be needed to be procured, whether it's staffing, whether it's ventilators or PPE or hospital beds, renovating locations or building hospital beds. We developed a need, and that need was turned over to the Department of General Services in order to do procurement. So generally speaking, DGS handled the vast majority of procurements. All the large and complex procurements, especially commodities related to the COVID response, were handled by the Department of General Services. I went over the different types of medical equipment that they were purchasing. MDH did issue some procurements. There were generally a limited number of procurements associated with the response, and we're continuing to build on that, on the number of procurements that we're handling now. Next slide, please. So the Procurement Division of Labor. So the overall process, which began in March and April, so all vendors that were offering services were sent to a particular email address at MEMA, where they were categorized by MEMA, and these particular vendors were then vetted by the Department of Commerce. And then our needs were supplied to Department of General Services as well as MEMA, and then Department of Commerce and Department of General Services, see if these vendors had the capability to supply the needed supplies in the required windows of time frame. So some vendors could supply things relatively quickly, while others there was a significant period of time before they could supply them. So DGS would then procure the products, and MDH, for the most part, would coordinate storage and in our warehouses in order or deploy them out into the field. Next slide, please. So for MDH procurements, the procurements that we handle, we typically, obviously, I think it goes without saying, we followed and continue to follow all applicable laws, rules, and regulations. And the overall process basically entails utilizing existing state contracts when possible, and if possible, utilizing non-emergency procurement protocols if time permits. And that's a big key. A lot of times with the rapidly evolving situation, there was no time to put out large RFPs or IFBs or large-scale procurements. It would just take too long to get a vendor on board, and therefore that would initiate our emergency procurement. And according to COMAR, would be to avoid or mitigate serious damage to public health, safety, and welfare. And we've given some key examples of some procurements we've done, which is contact tracing and staffing surge staffing for the surge. So next slide, please. So we call it a 45-day procurement sprint, and that was from March through April to get everything delivered by June of 2020. And we worked with healthcare planners and medical planners, as well as our clinicians on staff, to develop our need. And we developed a need for 2,000 ventilators. We were able to procure over 2,100 ventilators and PPE. And there's sort of a listing of the different types of PPE that we purchased. And the quantities were dependent on based on our projected need going forward. And also it does relate to the patient surge, whether it's med surge beds or ICU beds. And that does involve the creation of alternate care sites as well as advanced medical tents to support the number of hospital beds we would need to support COVID-19 patients moving forward. An important thing to note is not only are we dealing with COVID patients, but non-COVID patients as well. So all that modeling was built into our complex model for projections for hospitalizations and hospital usage. Next slide, please. So this sprint laid the foundation to increase testing from 50 tests a day in early March or mid-March to 50,000 tests a day, which we've been able to do. And we've contracted with various labs to perform these tests. Out of large test kits that we bought, the large pack of test kits, 98% of them have been utilized, and we expect them to be completely utilized, I believe, within the next few days. And we've done 15,000 contact tracings a week, and over 100,000 cases have successfully been reached since June of this year. Next slide, please. So the big question is, well, how much did you spend? And the answer is over $1 billion. And this is, we are still spending, so it's important to note that we are still continuing to spend. So we're currently compiling everything and all our spending and costs, but these are continuing to go up. So we spent over $1 billion in overall procurements, the vast majority of which, as you can see, has been PPE. We've also used it for testing sites as well as ventilators and testing services in order to provide testing to the state. Next slide, please. So here's a breakdown of the I know the other slide may have been a little difficult to read, but this table gives a percentage of total cost that was paid as well as the percentage there. I would be remiss if I did not indicate that our COVID-19 tests that we purchased do represent a small fraction of our overall spending of approximately around 1%. But our PPE levels were around 64% of our overall, and even though ventilators were a crucial role in our overall plans, the number of ventilators resulted in only 10% of total overall cost. Next slide, please. So we also wanted to share with everyone that while we did really, truly massive amount of procurement, we really wanted to thank DGS for their efforts. They went above and beyond to issue procurements, working night and day to find vendors and quickly move on them before other states or other countries were purchasing PPE or ventilators or other very needed sensitive items that were in very high demand. So in Maryland, how much of the $1 billion plus went to Maryland? So approximately a third of all our spending went to Maryland firms, around $345 million, which is a great achievement on our part, just because we were searching the world essentially for all these items. So it's great that a lot of the money was funneled into Maryland firms. Next slide, please. Here's a listing. It's probably a partial listing. It's not a complete listing of all the Maryland firms that were provided funding. We issued contracts with. We did start to denote some of the MBE firms on there. We can certainly provide a complete list of that as well. But that just shows sort of dollar amounts and where funding went within the state of Maryland. Next slide, please. So PPE. PPE has been a big hot button issue, and it continues to be so. So this gives a breakdown overall of the amount of PPE that we bought when it comes to a percentage. The vast majority was going to be was gowns. This is a percentage of cost, and the reason gowns is such a high percentage, it's just the cost associated with them. They're very difficult to find, and they're very expensive. N95s and KN95s are also a lot more expensive post pandemic versus pre-pandemic. And that really raised the price of them, and that caused them to be a higher percentage of the overall cost of PPE spending. Nitrile gloves, as everyone, I'm sure a lot of people have heard in the news lately, nitrile gloves are a hot button issue right now, and there is a increased demand for them, and as well as an anticipated shortage of nitrile gloves coming up into the surge, especially coming into January. So we are well aware of that, and we are moving to make sure that the state has sufficient supply of nitrile gloves moving forward. Next slide, please. This just gives a breakdown of what was been procured and the total cost, and the other pie chart was a little difficult to read, but just to give you a sheer aspect of the amount of PPE that's been purchased. We purchased over 244 million gloves, 52 million KN95 masks, over 17 million N95 masks, and gowns. We purchased over 41 million. And their relative percentages and total costs are there. Next slide, please. So the next slide shows what's been distributed. So out of everything that we've purchased, this is how much that we've totally distributed. So as Webster indicated previously, we have distributed out, whether it's to local health departments, whether it's to other healthcare facilities, to group homes. We have distributed out over 86 million pieces of PPE and related medical equipment. And this just gives sort of a breakdown of where they are, what types and the amount. So gloves, we've given around 33 million, surgical face masks, 23 million, and we've given, for N95s, we've given out over 8 million N95 masks. Next slide, please. So our burn rate. This is one thing we're keeping a very close eye on at the state is the burn rate for PPE, as well as our current cash that we have in order to determine our days on hand. As you can see in the spreadsheet there, we have our goal is to have a 60-day supply. And what that would mean is that if the supply chain stops for whatever reason, we would have a 60-day supply to sustain the entire state. Now, our burn rate that we're showing here is the burn rate for the entire state. And that does take into account, and I believe there's a footnote there that includes long-term care facilities, nursing homes, post-acute care settings, acute care hospitals, first responders, healthcare service providers, and others. So that was an estimate of what it would be statewide if we needed to supply that. And the goal, in coordination with the White House, was for the state to have a 60-day supply based on our burn rates. Next slide, please. So services. Services is something that sort of encompasses not just testing, but it includes contact tracing and staffing and equipment associated with that as well. We've done over $166 million in procurements for service-related procurements. Next slide, please. Here's a breakdown. If the other pie chart is a little difficult to read, it gives the percentage of the total cost as well as the amount that's allocated for each different type of services there. As you can see, the highest amount there is testing services, which is obviously fairly expensive, and we're testing quite a few people, up to 50,000 per day. So it's a lot of tests. And staffing has been another issue, which continues to plague not only Maryland, but a lot of other states, or the vast majority of states across the country. You can always make more PPE, but you can't make more staff. So staffing has been a real major issue that we anticipate to be an issue moving forward to staff, because not only is there going to be an issue in our alternate care sites, advanced medical tents, but acute care hospitals, nursing homes, long-term care facilities. And that's why the governor's initiative to utilize the Maryland Med Now website to recruit has been initiated, so we can get additional staff on board. Next slide, please. So this shows the volume of testing. We started out, I believe, early April through December. It just shows the sheer volume of testing. This is, I believe, a 7-day running average. 7-day total. So where we were going down to, I believe, 20,000 a week. Now we were doing in the neighborhood of very close to 300,000 a week, which is a huge testament to the efforts put in by the Unified Command to develop and really push testing, as well as contact tracing, which is really go hand in hand with testing to ensure we limit the amount of exposure. Next slide, please. So this is the number of PCR tests that were done by facility type. And what that does show is an even distribution of sort of where the PCR tests are being administered. So they're at urgent care sites, at hospitals, within the community. MDH is administering them there, at private practices, at doctor's offices, pharmacies, at nursing homes, assisted livings, et cetera. So we're very encouraging to see that it's not focused in one or two areas. It's a wide breadth of different entities that are continuing to test higher and higher volumes, which is very encouraging to see. Next slide, please. And this gives a little bit of a more thorough breakdown in case you wanted to have the data sort of behind the pie chart. It was sort of when it comes to different types, the number performed to date from March through December, as well as that percentage of the overall total number of tests PCR tests have been performed. And important to note, hospitals obviously are the leading, and urgent cares are a very close second. Next slide, please. So MDH procurement plans for the COVID-19 vaccination distribution effort. So we've talked a lot about our procurements leading up to the pandemic, initially in the pandemic and leading up to summer and fall. And now that the vaccines are sort of coming, there's sort of a new level of procurements that the state will be initiating, and has already started initiating, in order to ensure that we will have the PPE as well as ancillary supplies for vaccination. So the federal government, the federal government's been releasing information regularly regarding what they will release with the vaccines. I don't want to step on Brian's toes. Brian's will be going into vaccines in quite detail, so I don't want to sort of steal his thunder, but I'll go into it very briefly. So the Fed did indicate they will supply PPE as well as certain ancillary supplies for vaccinations. That was told to us early on. That information did change a little bit. We did get some updates, and the federal government did indicate that nitrile gloves will not be included in the PPE supplies that will be included with the vaccinations. It will include syringes, bandages, alcohol pads, and gauze pads, and other related items. They will be shipped separately from the vaccine. So vaccines will show up, and at some point afterwards, the associated ancillary supplies will be shipped by the federal government and will show up on site, or at least that's the plan. I do want to note for everyone that the information from the federal government has been changing, and it's been changing significantly here and there when it comes to various updates that we're receiving, and they are related to not only handling of the vaccines, but their life expectancy at different temperature levels, as well as what the federal government will provide and how they'll be transported. Next slide, please. So NDH and the Unified Command sort of made the decision to go ahead and procure goods and services to ensure that the state is fully prepared both for the distribution as well as for the administration of the COVID-19 vaccines that will come out. So while the vaccines will be coming, and I'll get into the cold chain storage, which is very specific, but we've done several procurements, actually numerous procurements for both distribution supplies as well as administration supplies. So while the federal government's telling us they're going to provide ancillary supplies, the state's being proactive to go ahead and purchase these items to ensure we have them readily available when the vaccines come so we can administer vaccines immediately. This does include syringes, Band-Aids, alcohol pads, gauze pads, the required PPE, biohazard bags, sharps containers, etc. I do want to also note sharps containers are not being supplied by the federal government. When it comes to vaccine distribution supplies, I'll go into a little bit more detail, but it is related primarily to cold chain storage, which has been a challenge I'm sure everyone's seen lately in the news. It's been a bit of a hot button topic, just the unique nature of the cold chain storage required for at least one of the vaccines. Next slide, please. So when it comes to the COVID-19 vaccines, and there will be multiple. I know there's two right now that are sort of in the news, and they're sort of the leaders, and they'll be out sooner rather than later. The first is the Pfizer vaccine, and that's going to be stored. That must be stored at -80 degrees Celsius. That's considered an ultra cold freezer. That is a special cold chain requirement. A lot of hospitals, pharmacies, clinics, other places do not have this specialized ultra cold storage. So that is a concern that the department's been working towards and has been issuing a procurement to ensure that the state has the capability to have that cold chain storage throughout the state. The next level is the Moderna vaccine, which is -20 degrees Celsius. This is the temperature of a typical freezer. So this is a very common cold chain freezer. So generally speaking, it's standardized freezer capacity is readily available in the open market at places like hospitals and pharmacies and other locations. If not, they're generally speaking readily available and can be acquired fairly quickly. And then the third type of cold chain storage, which may come up for one of the vaccines, is refrigeration, which is basically 4 degrees Celsius. And this is also very common. Most locations have some type of refrigeration. If not, they can, generally speaking, acquire it fairly quickly. So out of all these, the largest concern, obviously, is going to be the -80 degrees Celsius ultra cold, which is the concern we've been focusing on. Next slide, please. So in order for the state to prepare, as we stated, numerous procurements. We've purchased ultra cold freezers for the state in the event that the state needs to handle or hold vaccines. It is important to note that the plan is not for the vaccines to come to the state. The plan is for the vaccines to go directly to pharmacies and healthcare facilities and hospitals directly for where they will be administered. We have an abundance of caution, purchased additional ultra-cold freezer capacity in the event that there was a need for the state to do it, given the fact that information from the federal government has been changing rapidly, and things can change very quickly. Just to give an example, initially the federal government had asked states not to purchase ultra-cold freezers. And then weeks later, they asked where our ultra-cold freezers were for pre-positioning of vaccination. So that's something that we're very cognizant of is things are changing rapidly, so we want to make sure that we are prepared. We've also executed with agreements with vendors for dry ice, with dry ice suppliers, so they can supply dry ice statewide. Not necessarily just to the state, but any other providers that don't have their contracts. We can certainly utilize these agreements to get dry ice where it needs to be. It's important to note the Pfizer, which I don't want to get into too much detail, but Brian will talk about that next. But when it comes to vaccines, the Pfizer vaccine will come in a container that can be recharged with dry ice. We've also executed an agreement with a pharmaceutical company in Maryland to lease additional ultra-cold storage capacity as needed. We only sort of pay for the amount of space that we acquire. It is a secure facility that handles many other types of vaccines and has many other contracts with the federal government. So that will only be utilized on an as-needed basis, but we have the capability to expand there if need be. And we are initiating MOUs with other entities for ultra-cold storage capacity if needed. So we have the capacity to expand further. And as I indicated, the Pfizer vaccine can be recharged in the existing container that it does come in. So that's a plus for locations that don't have ultra-cold freezers. They can continue to recharge in the existing cooler pack that it comes in. Next slide, please. So when it comes to minus 20 degrees Celsius freezer capacity, MDH has leased a large walk-in freezer in order to ensure that the state has the capacity to handle vaccines. Again, we do not anticipate receiving vaccines. That's not the plan. However, we do want to ensure we have the capability to receive them if, in fact, things change and there's a need for the state to receive vaccines and hold them for distribution or administration. And we can certainly increase our capacity very quickly when it comes to freezer space if needed. We already have one walk-in, and we can certainly add another one if need be. And MDH also already has a large walk-in refrigerator, which is pharmaceutical grade on site that's built into one of our facilities that we have readily available and can store a significant amount of vaccines if, in fact, we do receive them. Next slide, please. So here's a breakdown of when it comes to ancillary supplies, a pie chart. The vast majority, about 50% of our ancillary supply spending has been on syringes. And the other ancillary supplies have taken up the remainder of it. It's important to note the cold chain storage is taking up a small fraction of it. All the large sort of pieces to this pie are associated with the ancillary supplies that we're purchasing to ensure that we can administer vaccines very quickly. Next slide, please. And this gives a breakdown, sort of the data behind the pie charts in case anyone's interested. This gives the percentages as well as the cost, which drives the percentages, but it also gives the quantities purchased in case anyone's curious. We are purchasing 7.5 million, or have already issued procurements for 7.5 million syringes, gauze pads, over 11 million bandages, over 9.5, and alcohol pads. And biohazard bags as well as sharps containers to ensure that we're able to safely administer vaccines where needed. And we will be sort of providing these to healthcare providers, nursing homes, other facilities, anyone else that would need them if there is a need moving forward. Next slide, please. With that, I will turn it over to Brian Moreau, who will talk about something more exciting about vaccines.
Thank you, Deputy Secretary Chaudhry, and thank you, Chairman Pena-Melnick and Rosenberg, for this opportunity to talk about a very important initiative. I am Brian Moreau, and I'm the Acting Assistant Secretary of Health. I'm talking about vaccine planning. Many of you have seen the press release that we've had, but I do want to review some key points that we're working on. Next slide. To start with, our overall goal is the equitable distribution of safe and effective vaccines to save lives and ultimately end the spread of the COVID-19. Our goal is to ensure that every Marylander who wants a vaccine can get a vaccine. Next slide, please. We've been planning for this for a long time. Since the beginning, both on the federal level and the state level, we've been planning since the pandemic began. In April, we had initial departmental planning meetings. By October, we had submitted our plan to the CDC. Also in October, we began securing the supplies, syringes, and supplies needed, as was mentioned earlier. By November, we started to convene our advisory committees. There are technical, minority health, vulnerable populations, and other outreach groups. By mid-November, Governor Hogan announced $10 million in funding for additional supplies. This is what we've been doing on some of what we've been doing on the state level, but preparations were also occurring on the national level. Next slide, please. Multiple pharmaceutical companies began developing vaccines and conducting trials. These clinical trials take place in 3 phases, with the last phase including tens of thousands of volunteers. Once a vaccine candidate has demonstrated a high level of efficacy and safety, the pharmaceutical company can apply to the federal government for an emergency use authorization. So far, only 2 pharmaceutical manufacturers have applied for this emergency use authorization. Currently, those 2 companies are manufacturing millions of doses in anticipation of federal approval. The federal government has prioritized these allocations for delivery already across the United States. And once approved, these allocations will be shipped directly to the providers at hospitals, pharmacies, and clinics. In addition to the vaccines, the federal government is also shipping the ancillary supplies, which we've discussed at length, that are associated with vaccine administration. This entire development and distribution process is monitored and assessed by the FDA and CDC to maximize security. Next slide, please. So let's talk about those 2 candidates. We have 2 candidates, Pfizer and Moderna. On November 9th, Pfizer announced that they had 95% efficacy. This is exceedingly high for most vaccines. On November 20th, they applied for the EUA, that emergency use authorization. Today, the FDA advisory committee is meeting and starting to review this. We are anticipating there will be approval and beginning distribution next week, the week of December 14th. Moderna has also announced a high rate of efficacy on November 16th. They applied for their EUA on November 30th, and the FDA is set to review their application on December 17th. We anticipate if their EUA is approved, that we'll have potential distributions the week of December 1st, December 22nd. Next slide, please. So our key considerations on how these will be distributed will be based on the federal recommendations. The CDC and their advisory committee on immunizations has set up recommendations. Maryland State has aligned our priorities with those recommendations. We are prioritizing those at the highest risk for this disease and those who have complications, and additionally preserving our critical healthcare capacity. Next slide. Those high-risk individuals will be in 1A along with our healthcare workers. We have seen the crisis that has occurred in the long-term care facilities, and we want to make sure that the vaccine gets to them quickly. We have allocated in our first tier, 1A, that healthcare workers, residents of, staff of long-term care facilities, and first responders. The way these priority groups work is a pyramid shape, as you can see, that continuously, as we move through stages, will get wider and wider to more and more individuals. The shape of this pyramid or the distribution actually ramps up very quickly. So there is limited doses and amounts during 1A and 1B, which is why we're prioritizing them. But as we move into phase 2 and 3, it'll become more and more, production will ramp up and more widespread. After we get through phase 1, or 1A, we'll start moving into 1B, and it's as we hit our criteria. There is not a set timeline for this. It is based on how many doses we get from the federal government and how much we can distribute and how much is actually administered. We will then continue to move into phase 2, people in critical and essential infrastructure roles. These could be those in crucial economic roles. It could be teachers. Those are all in our essential infrastructure roles. Also, people with moderately high risk of severe COVID-19 illness. Continuing, as it becomes more and more widespread, we move into phase 3, which is the general population. Next slide, please. We're looking at a safe and phased approach with the vaccines in our critical and high-risk populations, which we've stated before align with our federal guidance. We'll talk about the availability in a minute, but it is very limited at first, but will quickly ramp up. The CDC notifies us directly about the state supply and distribution. Next slide. Phase 2 begins when phase 1 targets have been met and the vaccinated target groups will begin with critical workers. It will continue through our phases until we reach our stated goal of every Marylander who wants a vaccine will be able to get a vaccine. Next slide, please. So how are we going to allocate this limited supply coming in? Maryland aligns as much as possible with the federal recommendations, and unless under certain circumstances precludes that. But in phase 1A, the doses we're anticipating getting from Pfizer are 50,700 doses. If we get Moderna during the week of December 21st, we're anticipated to get 104,300 doses. All of these doses will be designated to go to hospital healthcare workers, long-term care facility residents and staff, and our first responders. These are not set doses. These will continue week to week. These are just our initial doses. And as a common question comes up, these are full initial doses. We do not have to hold half of this back for further doses. The federal government is holding that. An example of that would be for Pfizer, these 50,700 doses. The federal government is already holding 50,700 doses in anticipation of that second dose. So we will be administering all of that. Next slide, please. So I want to talk about Immunet, which is our cornerstone of our immunization information system. It's been used in Maryland for 15 years. It is HIPAA secure. It is safe, and is designed to hold personal health information. We have had it assessed for its capacity and capabilities, and recently we've taken steps to enhance its capability and capacity. We have also had it evaluated for cybersecurity. Immunet is where providers will be placing their orders to get the vaccines. And as we move into further phases, they'll be able to place their orders and get them directly. In phase 1, they'll be placing their orders, and we will have to evaluate the distribution. Immunet is where all health records are stored, and every Marylander, every immunization that is currently being administered in Maryland is stored in Immunet. We have created a consumer access portal, which anyone can access at md.myir.net. And you can download your own personal immunization record, and this will continue even as we administer the COVID vaccines. You'll be able to track that. This is very important to ensure the safety, as the second dose that is required must match the first dose. So providers are able to look into Immunet and see if an individual, what dose they've gotten and when they received it. For each one of these doses, have to be given a second dose within, for Pfizer, 21 days is the ideal, and for Moderna within 28 days. Next slide, please. As Deputy Secretary Chaudhry has talked about at length about storing the vaccines, we wanted to provide you a visual of what these would look like. On your screen, you'll see two pictures. One is the shipping container that the Pfizer will come in to maintain that negative 80 degrees Celsius. It is insulated. It contains dry ice. It is also GPS tracked and constantly monitored for temperature variations to maintain that the vaccines are frozen at negative 80 degrees. As stated earlier, those shipping containers can also be used to store it. If we wish not to use those containers, or we need to move them from those containers, they would have to be kept in ultra-low cold storage. As you can see from the picture, the other picture is an example of what one of these freezers looks like. I won't repeat the efforts that we've gone to secure these, as we've talked about them in length. Next slide, please. We do know there's a lot of questions about the vaccine, and we do know that there's vaccine hesitancy. There are lots of questions that we know some of those questions right now, and we'd like to answer them to the best effort we can. We know that there are knowns and there are some unknowns. So let's address some of those common questions. Is the vaccine safe? Well, as stated earlier, these vaccines have been under trial for many months. Pfizer Vaccine has had 40,000 volunteers, and Moderna over 30,000 volunteers that were tracked. They found that not only is it high efficacy, which is that 95% roughly, but this is demonstrated high safety within those groups. So is there a question, are there side effects? Well, some have had side effects. They have been mild side effects that often resemble flu-like symptoms, maybe a cold, maybe a slight temperature rise, or more commonly is pain at the injection site. I will say that most have not had side effects. Is the vaccine safe for children? Well, that is under investigation. The volunteers for these programs and the studies that they've conducted have all been on those for 18 or older. They are enrolling children down to the age of 12, and they have plans to conduct trials on those even younger, but we are waiting for the data on that information. Will I need to get vaccinated every year? This is also under investigation. This has been, these trials have gone on for months. We have found that they have shown a high success rate, but we do need to evaluate whether they will be given every year, and we are looking at the studies and the information that is released. Will I need to wear a mask after getting the vaccination? We are recommending that you do wear a mask, that you continue with hand hygiene and social distancing. The vaccination at its effective rates will protect you, but we want to make sure that it doesn't spread. So we will encourage the wearing of masks, hand washing, and social distancing. When can I pre-register for the vaccine is another question. Well, that is based on the timeline of when we get the doses in and how many we get out. So as soon as we hit the stages in which we will be spreading it to the public, we will be opening up our pre-registration sites. Currently, they're targeted for the hospitals and nursing homes, and those are closed points of distribution. So we are not registering for those. A provider can register, but we are not asking everyone to register. Those will be closed pods or closed points of distribution. Next slide, please. I'm going to hand this over to Mark Martin, who is our Deputy Director, Office of Minority Health and Health Disparities.
Thank you. Thank you, Assistant Secretary Rose. And hello, everyone. Glad to be with you. Next slide, please. So let's talk a little bit about vaccine confidence and vaccine hesitancy. So we're in the process of developing a statewide communications campaign to be led by Governor Hogan. Our outreach efforts and communications efforts will be hyper-local and targeted, utilizing trusted community voices and partners. Our communications will address vaccine hesitancy by communicating clearly what is known and what is unknown. No speculation, but what is fact. Safety information such as expected side effects must be in a language that is easy to understand and culturally relevant. And communications will also provide rumor control and address misinformation. With the advent, as you know, of social media, rumors run rampant, and we want to make sure that we are forward-leaning and getting out ahead of that as much as we can. Next slide, please. So as a part of the planning, we've been developing 5 work groups: a technical advisory group, a mass vaccination and communications work group, a vulnerable populations and minority health outreach work group, a professional outreach work group involving commerce, and healthcare professionals work group. Next slide, please. So for the mass vaccination planning and outreach, the process for that group is to leverage trusted leaders and their voices to reach minority groups, especially that knowing that these folks have so much influence, we want to work with them as closely as we can. We also want to leverage thought leadership to shape outreach and messaging strategies to minority groups. We understand that with those minds in the room, we want to make sure we tap into as much thought power as we possibly can. And we want to leverage participant support of identified interventions targeting minority groups. Next slide, please. So the structure of the work group, we have representation from community-based organizations, faith-based organizations, local health departments, health professional organizations, industry, and state agencies. We were aiming for a balanced representation of not just geographically, but also professionally, so that we can have a good representation of all voices in the room. Next slide, please. So one of the things that we've done in terms of outreach, we organized, this is MDH, we organized the Hispanic Outreach and Support Task Force with a focus on targeting zip code 21224, which has been especially hard hit with COVID-19. So some of the things that we did was we distributed information sheets related to COVID-19 information. We distributed essential supplies, kits of essential supplies, non-perishable food items, PPE, wipes, those types of things to the citizenry. We guided MDH response activities also. Developed and implemented a communications and messaging campaign, working in lockstep with our Office of Communications. We consulted on our serology survey design. And also we participated in the primary care provider webinar series where we had experts from our office, the Office of Minority Health and Health Disparities, participating in giving information in that lecture series. And also, we worked very hard to make sure that we could get COVID-19 in the very beginning stages of the pandemic, get the data stratified by race and ethnicity. Next slide, please. So I mentioned information sheets. Here's an example of one. This one is in Spanish. We distributed these types of information sheets across the state, particularly in zip code 21224. As you see, they're pictorial. There's some good pictures on there, but pictorial in nature. We want to make sure that these were simple to read and culturally relevant. Areas included that we distributed these types of information sheets in Baltimore County, National Capital Region, and down on the Eastern Shore. We've also pushed these information sheets through our networks that have included faith-based organizations, community-based organizations, healthcare providers, and through our motor grantees and their networks. Next slide, please. Here are a couple more examples of the information sheets. The one on the left, that is Haitian, and of course the one on the right is in English. Next slide, please. So one of the things that we did in terms of responding to zip code 21224 was we employed the use of an audio sound truck. As you can see from the photographs, it's a converted flatbed truck with an onboard audio system that plays an MP3 file that we had developed with messaging content in both English and Spanish, speaking to best practices to slowing the spread. So the physical distancing, washing of hands, frequent washing of hands, wearing the mask. There was also on the truck, we actually had about 3,500 free masks during this campaign that we distributed to folks along the route. It was branded with banners communicating information on testing, contact tracing, how to get needed information for self-isolation support, and also the 3,000 information sheets that went out during that time period that we employed this sound truck. Next slide, please. So we need your help, okay? We want you to encourage your constituents to stay vigilant, to wear a mask, practice physical distancing, frequently wash hands, answer the call, and even now, at this point in time, get a flu shot. Get a flu shot. Thank you, and I'll turn it back over to Assistant Secretary Keith.
All right, we're happy to take any questions.
Do any members of the subcommittee, various subcommittees, HGO or appropriations, have any questions? Delegate Terry Hill. Can she be unmuted?
Let's try. Better?
Delegate
you.
Hill,
Yes,
please.
thank you very much. So I wanted to thank
Linda.
you, both of
Look.
the chairmen, all of the chairmen for pulling this together. And I wanted to thank the panel for their very detailed presentation. I do have a couple of quick questions. The first one has to do with the breakdown of the tiers 1A, 1B, 2, and 3. So I understand what we're talking about, the healthcare workers, residents of nursing homes, first responders. I'm not clear on who's in 1B or how we're defining the critical folks in 2. And the part B to that question is why exactly are we, I mean, I understand it ethically, but from a medical standpoint, I'm not clear why we're prioritizing residents in nursing homes as opposed to the frontline people who are going in and out of the nursing homes, bringing the virus with them. So I'm talking about the super spreaders, their 20s, 30s, and 40s, who are going all around the community. It seems that some of those injections we're giving to the residents should be going to our super spreaders so that we can have more bang for the buck and actually prevent more people from getting the infection. So breakdown on 1B and 2, and then
Sure.
Yeah.
Thank you. Thank you for that. It's a very good question. Within that, I want to be clear that this is for nursing home residents and staff. Even the part-time staff will be provided the vaccine during this process. So it's for anyone who works in the nursing homes will get it, as well as the residents of the nursing homes. So we are really hoping to address the idea of those who work in multiple agencies will be able to get the vaccine at what agency they work in. So within that structure of 1A and 1B, our target was following the federal recommendations from ACIP, that advisory committee on immunizations, and we have had unfortunately, most of our deaths have occurred in nursing homes, and so that is a high priority, is preventing the deaths. But as you stated, we also want to prevent the spread. We also must maintain our critical health infrastructure, which is why the hospital workers are also in that 1A. Did that answer that question? I want to make sure.
Not really. I really am not understanding. For instance, you don't explicitly mention prisons where we've had quite a few outbreaks. And by the same token, we're taking limited doses and giving it to residents. If we simply take the healthcare workers in the nursing homes, we can delay immunizing the residents because we're immunizing the people who are bringing the disease into them. We could then take those doses that we're not giving to residents, we could give it to the bus drivers and some of these people, the employees at the prisons, and some of the other people who you're delaying to 1B or 2, so that again, we are effectively saving more people from exposure than a resident who isn't seeing anybody except the already immunized people who are working with them. So that's what I'm asking about. So I'm not clear on who the 2 people are, the 1B people. But again, it's really about dealing with the source instead of putting out the small fires. And I understand ethically, it's hard to say to elderly folks who are dying of this, we're going to postpone your immunization. But when you explain, but we're going to get the people who are bringing the virus into your facility, and that's not just the healthcare workers, but it's all the people. And when you do that, the bus drivers and so forth, the people who come into the homes of senior citizens to assist them who aren't in the nursing home, that is also indirectly making sure that you're getting some of these underserved communities where we've seen the outbreaks, the black and brown communities where many of these workers come from. So I'm questioning why we're not diverting more of it to the workers more broadly. That's
Can you
really
pose a
what
question, please?
That was the question. Why are we not
Okay.
diverting it more to those?
Thank you.
We are prioritizing the nursing home, long-term care facilities workers. So they are within 1A. So we are addressing those. And again, our focus is including not just full-time, but part-time, maybe traveling from different agencies. And very quickly this will ramp up. As I stated earlier, this is not a stagnant number. It's not 50,000 and that's it, or 104 and that's it. Every week we'll be getting more doses, and as we get them, we'll be quickly moving through those stages.
All right, thank you.
So it's not a long-term process. It's very short.
Mr. Chairman, may I ask one more question? I have 3 more, but if I can just ask one, I'd be.
One short question for right now,
Thank you.
because we've got a lot
Are
of
we going to
others.
set up a side effects hotline? Certainly, we know that after the second injection, the side effects become more pronounced. Fever's up to 104. Do we have a mechanism in Maryland to find out what side effects people are having separate from whatever the federal government is doing? Are we making sure we're capturing that?
We do have mechanisms to capture any sort of adverse reaction that will be tracked, and we will be setting up a 211 line for individuals to get information. So we are tracking it, yes, and we are setting up information lines.
How, if it's not?
So we have multiple systems. When people enter into the, I'm trying to remember the vaccine administration reaction, that will be registered within our IT systems. Each healthcare who if you report those get logged into our Maryland system and into the federal system.
Okay, thank you. That's not a great system. Thank you.
Good. Next question from Delegate Sample Hughes, who has to leave the session, and then we'll go to Delegate Resnick and his subcommittee before we go back to the HGO subcommittee. Delegate Sample Hughes.
Sure. Thank you, Chair Rosenberg, and certainly apologize having to leave, but I think in these times we do have to run to our medical appointments when we can get them. To that end, I want to say thank you for the presentation. My question is around the procurement process. I know that many of us have seen nationwide 60 Minutes the other night as it related to the ventilators costing of $41,000, whereas it should have been roughly like $5,000 per ventilator. And unfortunately, Maryland was affected by that. My question is, beyond the exorbitant cost of the ventilators, what else were we charged as a state to that extent, to that amount, given the fact that we're needing to have, financial resources for additional PPEs and other things that we're in need of? I just want to know and ensure that our procurement processes is fine and in decent in order because of that cost that we have incurred for the $41,000 per ventilator. And I just don't want to make sure it's beyond the fact that Tiffany Waddell was a good friend with Blue Wave Medical Company. So if you could respond to that, that'd be greatly appreciated.
Thank you very much, Delegate Sample Hughes. It basically, it was sort of a supply and demand issue at the time. So whereas ventilators may have been $5,000 or $10,000, pre-COVID or pre-pandemic, it all depends on what ends up being fair market value at the time. So at the time, fair market value for anything fluctuates depending on the demand. So there's a significant demand for PPE as well as ventilators, various other medical equipment, and therefore whoever had them were charging more for what they were previously. So as an example, with the ventilators, the going market rate or fair market value at the time was $41,000 or more. This wasn't just Maryland. This was everyone else across the country as well as across the world that was paying these fees because that was the going rate. If you were not willing to do that, then you weren't able to sort of acquire these items. So unfortunately, while we all want to be very, very good stewards of state funding and be very cautious of spending, we try diligently to get the best possible price from the Unified Command as DGS did, but however, we were forced to pay fair market value in order to acquire the items. And I guess one note, try not to drag this on, but one note is if we weren't willing to pay that price, somebody else was, and they were going to jump in front of us and do this. I don't want to speak for Secretary Schrader, but I'm sure he shares my personal view that every life is precious, every life is priceless. And, the state at the time was trying to buy ventilators to save lives. And we wanted to make sure that every mail-order that needed a ventilator had one when they needed it. And we were, and at the time, we did what we had to do and paid fair market value in order to ensure the safety and well-being of Marylanders. So I'm sorry to answer, I think you asked for other items. So it wasn't just necessarily ventilators, PPE as well as other items was, and I believe I spoke a little bit about gowns. Gowns were higher priced as well. So were all other items related to PPE. So we were paying higher prices than they traditionally should be.
If I may follow up, has MDH or DGS made any changes in your procurement procedures since the spring?
We do. So I don't want to go into great lengths about since DGS is handling, but there has been initiatives taken to ensure the costs are more reasonable at the time as they come down. To give you an example, intimately involved and take into a little bit into the weeds, but nitrile gloves. Nitrile gloves are very expensive at the beginning of the pandemic, the beginning of the surge, back in March and April. The cost went down slightly over the summer, and they bounced right back up into the fall. And now they are much higher than before. So DGS has initiated statewide contracts and gone to great lengths to secure contracts, not necessarily just for PPE, but all related items. Disinfecting wipes and other items that are in high demand. And they put an invitation for bids and received the bids in, was able to try and get the lowest possible price for these items. That way we weren't initiating emergency contracts for the fair market value. At the time, they were more planned and they were negotiated ahead of time.
Chairman Resnick.
Thank you, Mr. Chairman. Thank you all for presenting. I did want to add before I asked my question, I believe Delegate Pat Young from my subcommittee has also joined us since I did introduction. So I just wanted to do that very quickly. I'm not going to beat a dead horse about the Blue Flame ventilator purchase or the South Korean test kits. I've written enough letters about that. I do have a couple of other questions, though, related to the procurement. The PowerPoint you posted showed about 33% of COVID-related purchases being made with Maryland firms, and 2/3 of that, 66%, outside of Maryland firms, presumably also international firms. You provided a very handy list in the PowerPoint of the Maryland firms, but since 2/3 of the procurements were made outside of Maryland, you did not provide conveniently a list for those purchases. So if you could provide to these subcommittees and committee a listing of all of the vendors that were outside of Maryland that amounted to the remaining 66% of purchases, I would appreciate that. I think that's equally as important as knowing who in the state got our money. So could you do that for us?
Mr. Chairman, happy to do so.
Great. I'm going to follow up also with a second question dealing with the vaccine distribution. I know there's been a couple questions of that already. What I'm still not able to wrap my head around is knowing the limited supply of vaccines that will be coming to the state initially. I'm still not quite sure which facilities are going to be getting this, whether it's, I mean, I get that it's hospitals potentially and nursing homes, but how are home healthcare workers? How are medical facilities not designated hospitals, like, for example, Kaiser health facilities that are integrated their services along with their insurance coverage, and other medical facilities going to physically be able to access the vaccines. I get who's on the list and I understand what phase one is. What I'm missing is the piece about how are these facilities physically going to get their hands on the vaccines.
So in the beginning, as you stated, level one, they'll be shipped directly to them. As we move into further levels, as that pyramid spreads out, we'll be shipping those to...
Okay, I'm sorry, then maybe I wasn't clear. How will they be shipped? How will they ship to Shady Grove Adventist versus Mercy in Baltimore versus a nursing home in Anne Arundel. What is the process of these facilities being able to get their hands on this?
So they would register through Immunet as a provider.
Okay.
That request for immunizations would go to the federal government, and then they would be distributed directly to their facility.
Okay, and all of these facilities are aware of this process?
We have announced that is how they will get them, is through Immunet. We've done outreach to those facilities. But if you know of some that don't have them, please send it to us. We'll reach out to them.
Because I have had several facilities contact me saying they've been on the phone with you guys for hours and hours and they can't get answers. So yes, I will send them directly to you then. With that, I have one final, it's actually a very simple question. When you do contract tracing, presumably it's by telephonic means and other means. When a call comes in, what does it say on the phone to let me know that it's contact tracing and not spam or a solicitation of some other variety?
Sure. I'll take that, Mr. Vice Chair. We work with Verizon, AT&T, Sprint, T-Mobile, whatever it's called now, to show that on the caller ID for cell phones, Maryland COVID, MD COVID, or if there's enough space, he'll say Maryland COVID trace. But generally speaking, it says MD COVID. And then on landlines, it's a form similar.
That's good. Okay, thank you. I've had questions about, people wanting to answer contact tracing calls, but don't want to get on a, 20-minute solicitation call for insurance. So they want to be able to get that. So, all right. Thank you, Mr. Chairman. I appreciate it. I don't know if there are other members of my subcommittee that want to, Delegate Valentino Smith. How can I have not known that?
Thank you, Mr. Chair.
It was an inside joke.
Hello to the members of the HGO committee. I know we're pressed for time. I have two things I wanted to try to do. One was to make a statement and request to Mr. Chaudry, and then ask a question to Assistant Secretary Mraz on distribution. So Assistant Secretary Chaudry, with respect to the procurements, I think we all know that the urgency of the pandemic created alternatives to the traditional procurement process. And Senator Pinsky and Chair Pendergrass sent a letter to the Office of Legislative Audits requesting that you look into it. I'm a member of the Legislative Audits Committee. My concern is that on December 1st, the Office of Legislative Audit sent a letter that I read directly in part from that said, in looking into the emergency COVID procurements, it is important to note that OLA has experienced some difficulty in obtaining timely information from certain state agencies that we deem necessary for our examination. For example, my staff and I were somewhat taken aback by a recent news article published on November 20th, 2020, which contained certain information that OLA auditors had requested a number of weeks ago from the Maryland Department of Health, but not yet received. So my statement to the panel presenting with respect to procurement is that we remain concerned that the Office of Legislative Audits is telling us that they're not getting the information that they need. And when you go back to that vast umbrella of agencies and multidisciplinary group that you sit with in emergency headquarters, can you please work with them to assure us that each state agency will be responding to the Office of Legislative Audits so we can better understand the emergency COVID procurements? That was my statement. I know we're short for time and just probably not needed for a response. For Assistant Secretary Mraz, you talked about— If I could
just do a brief response, Madam Vice Chair. First, Under Secretary Neal, audit compliance for the Department of Health, along with every state agency, was of the utmost priority. That will continue with Secretary Schrader. With respect to this particular audit, the Office of Legislative Auditors sent us their questions, and there were quite a number of them, on Friday, October 30th at about 12:30. We got them over 14 pages of response, including almost 30 supporting documents over about 100 plus pages on Monday, November 16th, around 8 p.m. And the Washington Post article ran on November 20th. We believe that in light of the COVID-19 response, a turnaround time of 2 weeks is a reasonable amount of time. I can attest to you, Madam Chair, that I worked on the legislative audit at 4:30 in the morning because during the normal part of the day, we were all trying to take care of other things. We will give the legislative auditors full compliance. We will give them as much information as we can, but it's also a matter of working with a lot of folks to get that information that they're asking for. I believe that the Office of the Legislative Auditors have a meeting with Acting Secretary Schrader next week, and we look forward to continuing the conversation.
Thank you, Assistant Secretary, Deputy Secretary Webster. I appreciate the sincerity of your response. And generally, Mr. Hook from OLA does not put us on written notice of concerns. That's why I wanted to raise it. With respect to Assistant Secretary Meraz, when you talked about distribution, you confirmed to us that you're using CDC guidelines for the state of Maryland and its citizens. And it's my understanding that CDC guidelines are prioritizing personal care providers for the developmentally disabled population as a category 1 sense of urgency because they go in and out of the house of the developmentally disabled and their care attendants, but that Maryland is not prioritizing them in category 1. So one, I want to ask, is Maryland making a definitive position to not follow the CDC guidelines for the developmentally disabled and the personal care attendants that care for them? And if so, why? Or is there consideration to move them from category 2 up, maybe to category 1B?
Thank you. And that is a very important population, and we understand how critical that is. In the ACIP recommendations, the advisory committee is not finalized yet, and we're still waiting for their formal recommendations that will come out after the emergency use authorization. So until we get their final guidelines, then we will be evaluating and working with our teams to evaluate them for Maryland and create the priority list on their on their recommendations from that. And that's what we're waiting for. We're still working on those final guidelines.
So it is that the developmentally disabled and their care attendants are not placed in category 2 at this time?
Not category 2. We're evaluating within the first tier where they would fit in.
Okay, so they will be in the first tier. I appreciate that. Thank you, Mr. Chair, and thank you to the HGO committee.
Mr. Chairman, do we want to keep going with the appropriations questions, or do you want to flip back to your subcommittee?
You're muted, Sandy. You're still muted.
Okay, sorry. Let's go back to let's do 3 people from HGO.
Okay.
Bagnell, Lewis, Young, and Cullison in that order. And then we'll get back to Delegate Young from your committee.
Perfect.
Okay.
Never mind, his question was answered.
Thank you,
Okay.
Mr. Chair. And thank you to the presenters. And you have anticipated many of my questions. You made a reference to what you call the 45-day procurement sprint. What are the major lessons learned from that period of time, and how will you specifically apply them to an enhanced due diligence process as applied to procurement of vendors, management of vendors, and distribution of the vaccines?
Thank you for the question, Delegate Young. It's a great question. So initially, with the procurement, as we've indicated, and as you acknowledge, there was desperate need for items. And as we move forward, we've given the example of the invitation for bids for PPE and related items. And we're trying to be more methodical with procurements to ensure that we're able to procure items for the best possible price. And I think I went through the slide deck where we're trying to utilize existing state contracts if we can that have pre-negotiated prices in them. By default, then we'll go to traditional procurements where we put things out for bid for a limited number of time on our online system and request bids. And then what we would, if there's an urgent need for items, we would be issuing emergency procurements only as a last resort. But the vendor vetting process has increased significantly throughout this process, vetting vendors more stringently and ensuring that we are coordinating with vendors that can deliver the goods when they say within a specified time period. And we are coordinating with Department of Budget and Management to vet new processes, such as vetting additional vendors. But I guess there's a lot of lessons learned here. Obviously, this is an unprecedented occurrence here, and hopefully once in a lifetime. And hopefully a lot of lessons learned here can be moving forward and collaborating additionally with Commerce when it comes to a lot of various other items with additional collaboration and ensuring that we have we can put things out for competitive bids as much as possible.
And a quick follow-up to that, will you work closely with the AG's office to prevent price gouging?
Absolutely.
Thank you.
Delegate Bagnall.
Thank you, Mr. Chair, and thank you everyone for your presentation today. I wanted to circle back to the phase 1 and ask about 2 communities I'm concerned about. They may be implied, but I'd like them to be a little more explicit. And that is our behavioral health community, both providers and patients. There's good evidence to show that patients have an increased susceptibility to COVID-19, and because of COVID, there's been a massive disruption to the care of people with mental illness and substance use disorders. So they may fall under healthcare workers, but I would like that to be a little more explicit. And the other population is essential support staff, because we had we've going back to Delegate Hill's point, we have seen support staff within not just the incarcerated community, but within the healthcare community that didn't have adequate PPE, that are contracting the virus, but also that are going back and forth into their own communities. And so I want to make sure that they are captured in that phase 1. Can you speak to whether or not that they are explicitly in that population, or is that determination not been made?
So thank you for that question. And my background is behavioral health, so I'm very much in tune with that population, and they are very important to our effort. So in those who work in the behavioral health hospitals are also considered hospital workers and will be included in that phase 1. And as we move through that, essential workers, as you stated, will also be within phase 1 as we move through them. So those are my short answers to your essential and behavioral health.
If I can just do one follow-up, does that include like outpatient services as well, or is that simply in inpatient services?
We are prioritizing those in congregate care since the spread is very high there, but all of those workers are considered healthcare workers.
Thank you. Thank you.
Delegate Cullison.
Am I on now?
Yes.
Okay, thank you. I want to thank the chairs of the subcommittee for allowing me here and for allowing me to ask questions. So thank you. I have one which is, I think, a yes/no question, and one which is a follow-up from some questions. The yes/no question is regarding the provision of PPE, and I'm wondering when you were calculating the number of gloves that are needed to meet that standard of 60,000, were you including folks who work with the developmentally disabled population? So those folks who are supporting people in groups, homes, et cetera, and are mostly funded by Medicaid. Are those PPE needs in your calculation for that 60%?
Yeah, yes. And just to give you a little bit more information, we've been distributing PPE to DD providers. Generally, the process works as just like almost any healthcare provider. If you submit a request to, let's just say, the Montgomery County Health Department, they'll take the request. If they have the supplies, they'll provide it directly. And then if they don't have the supplies, they'll put it through the statewide incident management system to the state for distribution potentially later. Obviously, once we got through the initial 45 days, the basic request to all providers was to try to obtain supplies through the normal supply chains to the extent possible.
So that there's an awareness of the need to stockpile some of that, as given the needs, right?
Yes.
Okay. So the other question is, I want to circle back to Delegate Hill's comments around, I absolutely understand the need to prioritize, the limitation on the number of vaccines we're going to get. But I think, I'm hoping that there's going to be a very thoughtful strategy around the prioritization, because while I'm hearing, we're very clear about who's in that 1A category, but it is still not clear to me, even after the discussion this afternoon, where home health aides are fitting, where community aides are fitting, where hospice workers are fitting, where are the DD providers fitting in the vaccine? Are they all in 1B? Could they be moved up to 1A if the vaccine were given to the workers first and the residents second? So I guess I just need clarification around where those workers are, because those workers are in the general population. They're not they're not working in one location. I mean, they're working in one location, but they're not staying there. They're in and out. So it feels to me like that's a really important priority, even in that 1A, tiny tip of that triangle, if it can be there.
Delegate Kellison, I'm just going to, again, my colleague, Mr. Moroz, has answered questions and along those lines this entire afternoon, but let me just try to make it really simple. Right now, we know from the federal government where we're getting the vaccines and to whom. They're going to nursing homes, residents and staff, and hospitals. And it's for the critical hospital staff right now that are on the front lines. Beyond that, we don't really have much information from the federal government as to when more vaccines are coming or how many and what type. We generally know that we'll be getting more vaccines week on week on week, and we will be working with our federal partners, like Mr. Moreau said, to flesh out, if you will, the other tiers. It's a little bit hazy right now because we've got about a 2-week forecast. Beyond that, I think one of the very first things I learned when I was working in Barbara Mikulski's office was do not ever overpromise. You have to be able to say a promise made is a promise delivered. And in this case, it would be unfair to the citizens of Maryland for us to say one thing and not be able to deliver on that.
So I understand that and I appreciate it, and I operate under that same mantra. But I guess, are you saying then that the federal government is requiring that the vaccines go to hospitals and go to long-term care facilities and be used solely on the residents and staff of those facilities? Is that a mandated use of this first round of vaccines?
No, ma'am.
So we have some flexibility and could indeed take some of those that might have been used for residents and use them for those who are serving our DD population, our hospice patients, our community, our folks in the community health. We have that flexibility under the federal guidelines.
Delegate, that's a little bit more of a nuanced and complex question. I'm going to turn this over to my colleague, Mr. Moroz.
Could I ask, we need to suspend, if I may. Dr. Moss has to leave by 3 o'clock.
Oh, I'm sorry. Okay.
No problem. You didn't know. Dr. Moss, this may be abbreviated, but the microphone is yours once it gets turned on. It is on. It's yours to present your testimony, and then we'll go back to the questions of state officials. Dr. Moss, thank you for being here.
Yes, yes, Mr. Chairman, and I want to be as helpful as possible to the committee, and
We appreciate that.
this has been a fascinating discussion, and I think, you know, what my presentation is about is some of the background to what Assistant Secretary Moreau's presented. And so I hope it's useful, but it's kind of the background to the discussion around the allocation. But what I recognize and what you are all really wrestling with is that the devil's in the details. And there have been a lot of kind of high level thinking about how best to allocate and achieve equitable access to COVID-19 vaccines, but it really comes down to the details. And I recognize what you are all struggling with, you know, with specific groups and the need, but on the other hand, the need to prioritize when you have limited number of doses. So what I can do is go through rather quickly this presentation. Some of it, you know, may be redundant at this point, but it'll give you a little bit of the background of the thinking. But it really comes down to the types of discussions you're having here on the actual details. I will say one thing, though, in response to some of the very important questions that Representative Hill raised. We do not yet know whether these vaccines actually prevent transmission of the SARS coronavirus 2 virus. The trials, the phase 3 trials for both the Pfizer and the Moderna vaccines had as their primary endpoint prevention of disease, whether that's mild, moderate, or severe disease. They did not evaluate whether or not these vaccines actually prevent transmission. We suspect that they will, but it is possible that a vaccinated individual could have an asymptomatic infection and still transmit the SARS coronavirus. So part of this, the struggle here is, you know, what are the initial priorities when you have a very small a number of doses? And so, you know, do you focus on the potential transmitters, or do you really initially try to prevent severe disease and death and try to preserve the healthcare system? And I think this is what Assistant Secretary Moreau was presenting and what is coming from the Advisory Committee on Immunization Practices, that we need to preserve our healthcare system because that will prevent deaths. And we need to prevent deaths in those who we know are at very high risk. And close to 40% of individuals who've died in the United States are residents of long-term care facilities. I think when we know more about whether these vaccines actually prevent transmission, we can have, and we have more vaccine doses available, we can begin to target those transmitters. That's another approach to trying to get a handle on this pandemic, but perhaps not the approach early on in this very early phase. So again, I'll go through very quickly my presentations and then happy to take any questions, and we'll go to the next slide. There's been a lot of thinking over the past several months, but again, at high level, and as I said, the devil's in the details here, and that's what you're wrestling with. There was an interim framework for COVID-19 vaccine allocation and distribution that was written and drafted in August of this year by the Center for Health Security on Johns Hopkins that laid out some higher level principles that we've just been talking about. And perhaps more with more influence was the National Academies of Sciences, Engineering, and Medicine that also published a high level but comprehensive report on the framework for equitable allocation of COVID-19 vaccines. These were efforts to think through the things you're struggling with right now in your discussions. You know, who gets the vaccine first? I'll just talk about the National Academies very briefly. Next slide. So their goal was to reduce severe morbidity and mortality and negative societal impact due to transmission of SARS coronavirus 2. It's not, the original goal was not to really prevent all transmission, but to reduce the morbidity and mortality. That's the focus on particularly on the residents of long-term care facilities and their staff, and the negative societal impact by protecting our healthcare services. Next. So they laid out this allocation framework with the goal, criteria, and 4 allocation phases. I'll talk about that. This work was actually requested by the NIH and the CDC. So this kind of underlines some of the points that later came out in the Advisory Committee on Immunization Practices. They had three ethical principles: maximum benefit, equal concern, mitigation of health inequities. They also had 3 procedural principles: fairness, transparency, and evidence-based. And I won't go into details here, but there was a lot of thinking at a very high level about both the ethical principles and the procedural principles. Next slide. These are the phases that were laid out initially by the national academies. And you can see this, it differs from what actually came out in the Advisory Committee on Immunization Practices and what Maryland is now considering. They had this jump start with high-risk healthcare workers. That's consistent with the ACIP recommendations, but also included first responders in that phase 1A. And then phase 1B, people with all ages, with underlying comorbidities that put them at significantly higher risk, and then other adults living in congregate or overcrowded settings. Now, the National Academies didn't know how many vaccine doses are going to be made available initially and how that's going to roll out. So these were their initial thinking. They very importantly referred to them as phases to capture that very important temporal aspect that this is really trying to figure out a way, as more vaccine doses become available, who should be the priority groups. Again, in the interest of time, I'm not going to go through all of these, but this was kind of the underpinnings, if you will, of the ACIP recommendations. Next slide. Yes, so the ACIP on November 23rd published in the Morbidity and Mortality Weekly Review their ethical principles, again, drawing on the national academies. So, and the point here I'm trying to make is that there are ethical principles that underlie this thinking. Again, you're wrestling with with the details on this, and that's very important. But there are some underlying ethical principles: maximizing benefits and minimizing harms, promoting justice, minimizing health inequities, and promoting transparency. So again, this was the ethical principles that guided ACIP. Next slide. And then as Assistant Secretary Moreau's laid out, it was in December 3rd that the Advisory Committee laid out their prioritization. And now these are federal recommendations. They're not mandates, as was just clarified. And as Assistant Secretary Moreau's highlighted, this could be modified after the discussion today and after an emergency use authorization is granted by the Food and Drug Administration. ACIP is going to meet again because they recognize that there may be particular characteristics of the Pfizer vaccine that may require modification of this. I don't anticipate that this will change, but these are still are not kind of the final guidelines, as Assistant Secretary Moreau's highlighted. But you can see here, the Advisory Committee on Immunization Practices recommended as interim guidance that both 1, healthcare personnel, and 2, residents of long-term care facilities be offered COVID-19 vaccine in the initial phase of the vaccination program. But then they go on to say that state and local jurisdictions are going to use this guidance, but it's not a mandate. And then that ACIP will consider vaccine-specific recommendations and additional populations when an FDA-authorized vaccine is available. That's what we're anticipating in the coming days. Next slide. Actually, I took some slides from your website, so let's just go through we can go to the next one. Assistant Secretary Moreau showed these slides. Next one. And next one. I just want to highlight, just because I'm a public health person, global public health person, that these issues are being discussed and debated at the global level, not just in the United States and at the state level. There are even bigger challenges in trying to think about equitable allocation across countries. And Gavi, the Vaccine Alliance, and the World Health Organization is wrestling with these issues themselves. And then the last slide was a webinar that we hosted at the International Vaccine Access Center just this past Monday. I anticipate this recording will be made available soon, but we had Dr. Chan and Dr. Jarasa present and discuss these issues, moderated by Josh Sharfstein. And I'll stop there. I realize it went quickly, but you guys are already way ahead on this discussion. I wanted to provide some of the background thinking, and I'm happy to take any questions.
Are there any questions for Dr. Moss? I don't see anything in chat or anybody raising their hand. So thank you, Dr. Moss. We will no doubt call upon you again and the Bloomberg School in the future. So we appreciate your patience and appreciate your input. So thank you very much.
Thank you, Mr. Chairman, and we're happy to be of any help that we can.
Thank you. Let's go back to Delegate Johnson and then Belcastro.
Thank you, Mr. Chairman, and thank you, panel, for making a presentation today. I want to get some clarity here on what is the CD's role in determining the vaccine priority versus Maryland Department of Health's role, and how much flexibility does the Department of Health have in determining priority groups within phase 1 and 2? Whoever's best suited to answer that.
I'll take that question. Thank you for that question. And I will tie it into the previous question before Dr. Moss came on. The CDC Advisory Council on Immunization Practices gives recommendations, and we are advised to consider them. So we do have a panel of experts that we meet that will review those recommendations and help us set our policies in that. It is not mandated. I must say, though, in one part, if we do want to participate in the long-term care facility pharmacy program, which is offered by the federal government, which will allow for nursing homes and assisted living to be vaccinated by CVS and Walgreens in that federal agreement, there are stipulations that if we opt into that program, which we have, that we'll be vaccinating all residents and staff at those organizations.
And one more, Mr. Chairman, quickly.
Certainly.
So you've entered into this agreement. So is this going to be a mandate for healthcare workers and a nursing home and assisted living facility workers? And who exactly has the authority to mandate the vaccine?
The agreement is just for the pharmacies to provide the vaccine to the long-term care facilities. It is not a mandate. It is, the requirement is in our participation in the program, but not a mandate.
In addition, Delegate Johnson, with respect to the mandate part, it's written into state statute, and then there is specific provision for opt-out. So there's no mandate per se. Like if you don't get the flu vaccine, for example, it requires you to quarantine and wear, or not quarantine, but wear PPE, don various other gear, and take certain procedures.
Okay, thank you very much. Thank you, Mr. Chairman.
Thank you, Delegate. Delegate Belcastro, followed by Delegate Chisholm.
Thank you, Mr. Chairman, and thank you everyone from MDH for being here today. As you know, in mid-November, it was announced that $10 million in CARES Act funding had been allocated for vaccine planning and distribution. My question is, can you provide some clarity on how MDH plans to spend this money?
Thank you, Delegate Belcastro. We actually provided in the slides, and happy to, I'm not sure if we can bring those back up, 43. Yep, so, slide 43 shows our spending. So out of the $10 million that's been allocated, we've spent a little bit over half of that, $5.5 million approximately. That's gone to ancillary supplies, syringes, Band-Aids, alcohol pads, sharps containers, biohazard bags. Thank you for bringing that up again. And it also is assisting with all our ultra cold storage requirements, what's also called freezers, the dry ice contract. there is PPE associated with cold chain with dry ice handling. That is a cryo apron, dry ice scoops, cryo gloves in dealing with dry ice and other items related to that with ultra cold. So all of those, it's slide 43. So all of those is a detailed listing of what we spent so far, and we're continuing to look at our needs, and PPE will be one of those, gloves in particular, will be sort of allocated towards that, $10 million.
Great. Thank you so much.
Delegate Chisholm, and then last set of questions from Delegate Pena-Melnick.
Thank you, Chairman Rosenberg. And in honor of Chairman Resnick, I'd like to ask a quixotic question, but it is a question that I would like to have answered if somebody could answer it from the Department of Health. So going back to the first 500,000 $9 million test kits, I've talked to several different lab people and done as much research as I can, and I've continued to be told they did not meet up with the FDA instructions. In fact, they were almost in reverse. But I was also read and have been told that they were missing the swabs and the reagents. From what I understand about test kits, that is the test kit. So can somebody please report back to both committees what exactly was in those first 500,000, so I can answer my constituents and the taxpayers on what exactly we did and why was the procurement wire of 9 million asked in the middle of the night?
Delegate Chisholm, I think it's important to note that as we provided to the legislative auditors, we gave them the exact information. The difference between the first shipment and the second shipment was the first shipment their formulation of those assays did not correspond to the emergency use authorization listed for the lab genomic assays on the FDA website. They were returned to the manufacturer, I believe, on June 20th or so.
Did we know that before we purchased them? Or was it a surprise to us when they got here?
It was a surprise to us, sir.
And so you're saying that the test kits were actually complete, they just didn't meet the correct FDA guidelines and rules. But they had swabs and they had reagents in them?
No, sir, that's a different question. About May 13th or 14th, the State Public Health Lab discovered when they examined it as part of the validation study that the assays were not consistent with the formulation approved by the FDA's emergency use authorization. The reagents and the swabs, those are different components. So we had to source the collection swabs separately.
So they did not come with the test. Okay, so that's not part of the test kit. So I'm still unsure what a test kit is if we're getting the reagents and the swabs from a different source. What is in a test kit? Can you tell me what's in a test kit that we bought?
Depends. That's an incredibly complex question, sir. There's numerous testing platforms, and then there's various components that go into that. It's more or less a 9-step process, but basically a test kit in the sense, as related to lab genomics, it provides the matrix by which RNA can be amplified such that it can be then detected at a different stage in the process.
That's a PCR. So we're taking the DNA and amplifying it, which is correct.
No, sir, it's RNA. This is a virus.
So I thought we were taking the DNA out of, okay. From what I've heard about PCRs, that's semantics at this point. I just want to know what exactly was missing from the test kits, and you're just telling me the instructions didn't match up. It's very frustrating when I'm answering this question constantly and nobody seems to be able to give us a straight answer on what really came, because we know for sure now we didn't use any of those 500,000. Then we had to upgrade. So I didn't know what the upgrade included, the right instructions, the FDA approval. I'm looking for, and I'm not personally asking you. I know it's not you. I just want an answer.
Well, sir, the upgraded kits, they met the EUA. After delivery of the first shipment, we learned that the manufacturer had the upgraded assay. It had better controls for extraction of the RNA. and we went with the upgrade, just like you would with a phone or any number of other things. And as Mr. Chaudhry reported shortly, we have used up 490,000 of that 500,000 second shipment. We'll probably be done using it in the next day or two, probably by Saturday. And unfortunately, as a result, you might not have the pleasure of being tested in Annapolis with them. But if you go down to the Annapolis test sites currently, today or tomorrow, you might have the benefit of being tested.
But if I bought a phone and it didn't work, I wouldn't have to pay for an upgrade.
Well, sir.
It's a bad analogy, Webster.
Well, sir, again, to make it really simple and real clear, back in April or May, we didn't have anything. The original test kits might have been used using a custom lab process, and it depends on exactly what stage, but back then it would have required federal government permission. It was more efficient to pay some more money, get the upgraded kits, and use them. And we've been using them, sir.
Thank you, Webster. I'll table it for now.
Thank you, Delegate. Delegate Vice Chair Pena-Melnick.
Thank you, Mr. Chairman, and thank you for everyone that has presented. I have a couple questions, and the first one that I have is the department testified that the state will get 155,000 doses in the initial allocation. In Maryland, we have 24 jurisdictions, 23 counties in Baltimore City. So my question is, how are you allocating the vaccine? Have the county been told how many doses they're getting? Can you answer that one first, please?
Yes. So in phase one, because it's a targeted outreach with limited, we're doing it by facility, not by region. We're distributing them to the hospitals and to the nursing homes. Well, we're actually distributing it to CVS and Walgreens, who will then assist in addressing the nursing homes. So in phase one, we're really focused on the workers in those. So it's not by a region or population, it's by the hospital itself, and we should have enough. We're looking at about 300 doses by the end of the December coming into the state. Those are as far as our projections from the federal government go out. So that's how those are being allocated.
So there are a number of major healthcare systems that span multiple counties, as you know, and these systems are probably some of the best positioned to provide the vaccine at scale. Are you making any efforts to coordinate between the counties?
We're coordinated. We do have coordination calls with local health departments on frequent basis, if not weekly, sometimes more than that. We're also coordinating with the hospitals throughout the state because, again, the first doses that come in will be targeted to the hospitals across the state, and we meet with them also on a regular basis.
Okay, so you have a stand, like you're meeting constantly every week?
Yes, we meet with the local health departments every week.
And I saw, if I may, Mr. Chair, I saw you had your plan to basically do outreach in the communities of color. As you know, out of the 24 jurisdictions, Prince George's County has the largest, largest number of COVID-19 cases. As of today, 45,871, I believe, followed by Montgomery with 37,738, followed by Baltimore County with 32,853, and then Baltimore City, 19,255. The zip code with the largest number of COVID-19 cases as of today is 20783, which is with 3,823 cases, which is the Latino, Brown, and immigrant community. So I saw the outreach that you have, but that's not enough. You're going to need to really go the extra mile because there's no trust in the vaccine in the Black and Brown community because of the abuses that we have had in the past, in the racism with those two communities. So are you doing the radio? Are you doing the TV? Are you going to get trusted source? I mean, I know the governor is going to be leading the statewide effort, but he's not the right face for those communities, with all due respect. So what are you doing about that community? And then the last question is, what are you doing to outreach the "it's all a hoax, I won't wear a mask" community? Because we have heard from nurses that they show up at the hospital sick and they're still saying it's all a hoax.
Thank you for that question, Delegate Pena-Melnick. So what we're doing with our outreach group is we understand that we've had a focus on mass media and social media to reach folks, but we're also targeting now grassroots efforts. So the outreach group is comprised of community-based organizations, faith-based organizations, academia representatives from the local health departments, and they are providing thought leadership to help shape our strategies. So we understand that there's a lot of mistrust out there right now. There's a legacy of mistrust, and that's validated. And so we are working to develop messaging that will counteract that, mitigate that, because we understand that this is going to take all of us for the right collective impact. So we're shaping strategies, we're shaping and developing interventions, and we're bringing in the voices of the community. We're going to be using trusted voices also, leaders from the community, to help us here to make sure that we get as much participation in mass vaccination participation as we possibly can.
And make sure that you work with the NAACP, Casa de Maryland, and make sure that what you don't have as a department and as a government is you don't have dedicated money for translation and interpretation. You contract it out. You must make that an essential part of the government as well. And tell us, what are you doing for the ones that say it's a hoax, I won't wear a mask? What are you doing in those places?
So with those, that goes to our communications and messaging. We want to attack that through social media. We want to look at perhaps Facebook Live town halls. The goal here is to have the trusted voices, the people in the community on the ground who are trusted in those communities to be the front line to mitigate those rumors, okay? Because a lot of it is just crazy, so to speak, but quite frankly, there is a validation because of what's happened in terms of history. So we want to make sure that people of color, black and brown people, are carrying that message to mitigate those false rumors that only serve to hurt the constituencies that you and I and everybody here care about.
Thank you, because you have to spend some resources to do that. Thank you so much. Back to you, Mr. Chairman.
Thank you, Delegate, Madam Vice Chair. I believe we are going to move on now to the representative of the counties, Dr. Travis Gales. We want to thank the department very much. We will remain in touch with you during the interim, and then we'll be seeing you quite a bit, no doubt, during the session when that begins. So if I may, thank you, Dr. Travis Gales, Health Officer for Montgomery County, for being so patient. And I would remind everyone that after Dr. Gales, we will then have the hearing on the Medical Marijuana Commission with the goal of finishing by 4 o'clock. Dr. Gales, thank you.
All right. Good afternoon, and thank you, Chairman and Chairman Pelnick. So I'll be quick. I'll go through this to get the time. We know that vaccinations and immunizations are a fundamental part of the public health foundation and our ability to protect and keep folks safe. We understand that the expedited nature of the process that went into development of these vaccines has caused alarm, and given historical experiences that were just discussed within certain communities, may cause some issues in terms of being able to effectively disseminate it within different communities. And health disparities, not just related to COVID, have existed long before COVID, but COVID has exacerbated those disparities within our communities, and thereby ensuring that high levels of coverage are needed to add for extra protection in different communities to mitigate those disparities from being further exacerbated. The local health departments have worked closely with the MDH to roll out plans as groups and priority groups are clarified. Capacity is further explained and determined in terms of what percentage of the vaccine each of the jurisdictions will receive. And more guidance is on the way to guide our processes. And as the representatives from MDH pointed out, we have been working closely with them and meeting with them frequently. We have a standing meeting with the Deputy Secretary and Secretary on Mondays and Wednesdays. And now we've created a Friday meeting that is specifically focused on mass vaccination planning. Now, as it specifically relates to the local needs of the jurisdictions related to vaccination, we have common themes. We're all looking to beef up our staffing, and this is in particular of particular importance given that we are still actively addressing the pandemic in terms of testing and outreach and other methods of our response, including contact tracing. And so a lot of us are doing the exercise of trying to find new staff, repurpose staff, particularly those with clinical skills, to the vaccine component distribution plans, as well as being able to backfill those positions with other staff to continue the active pandemic response. We continue to form and work with our partnerships with our health systems and our assisted living facilities, our nursing homes, and those types of venues, because as has been laid out in the previous presentation, they will be distributing lots of the vaccine directly to their workers and staff and residents without, local health department interference. We're continuing to need further guidance and guidelines. So many of the questions that you all asked, to clarify some of those things, we have some of the very same questions and are awaiting further guidance from the state as we devise our local plans for distribution. And some of the other concerns that we have in terms of additional support have to do with outreach. Now, we're building an infrastructure to be able to deliver vaccines effectively and seamlessly, but that's built upon the assumption that people will take it when it's offered. And we know that, as this was recently discussed in the exchange, that there are a host of issues that influence and inform an individual's choice whether or not they would take the vaccine. So we know that the state has communication plans in place. I can share what we're doing locally is we are working to identify key stakeholders in numerous different communities, building upon our existing groups that do that work. For example, we have a host of two minority health initiatives and a minority health program, one of which is actually conducting surveys within the community with, again, key stakeholders to find out what are the perceived obstacles and barriers to getting the vaccine, what are the common myths and perceptions about it, so that we can actively construct a program that targets those specific needs and questions. And we are also looking at how to leverage social media and other platforms to be able to, again, dispel some of those myths, not just in communities of color, but other communities that may have issues or concerns, whether it's related to the historical precedent of public health or related to, for example, we've received some feedback that there are a number of folks who are concerned about the expedited nature of the process, the approval process. So what we're working to do is to do some social media related to that. Based upon the prioritization of the different groups, I will likely fit into one of the early categories, being a healthcare worker and public health responder. And so, recognizing my demographic and recognizing my place within the community, we're looking to publicize that and to be open and talk about what my experience and what others' experiences are, to be transparent to folks so that they understand what may happen when they get the vaccine, as well as looking at how we can potentially take some of those early questions that people have as concerns and potential barriers and address those proactively through a series of webinars or short messages that will have good penetration through the community. I will stop there, but that's a 30,000-foot overview of where we stand as the local health departments and how we're working with the state, some of the additional needs and concerns we have, and particularly some of the efforts that we have targeted towards outreach to different communities. Thank you.
Are there any questions for Dr. Gales? Seeing none. Oh, sorry, Delegate Hill. Thank you for being vigilant.
Thank you. And Dr. Gales, thank you very much for your patience this afternoon and for being here. Just real quick, from the local public health standpoint, you heard a lot of questions that we had about how this distribution is going to take place from MDH. Are you feeling like you're adequately able in this first distribution to make the public health worker 1A people who are not based in hospitals, who are going into homes, dealing with the disabled, et cetera? Are you sufficiently in terms of dry ice, freezers, the time you need, other than the personnel, which you said is still a problem? Are we going to be able to make sure that our healthcare workers, other than those who are based in the hospital, who want the vaccine can get it?
So I think that's a great question. One that, in fact, while I've been waiting, have been having conversations about, trying to, assess where we stand locally. I think that's going to vary by each jurisdiction, but I can say that, all of the jurisdictions have been working to secure, making sure that they have adequate freezer space, making sure that they have adequate packaging and those types of things. Now, a lot of this will depend upon which of the vaccines we will most likely get as a local health department, because as was laid out, the Pfizer vaccine requires much more stringent refrigeration requirements versus the Moderna vaccine. At this point, we haven't had it confirmed, but it looks like we will most likely be getting the Moderna vaccine, which would allow for utilization of, for example, all of the freezers that we have currently for our immunization program for other vaccines could be used for that particular vaccine. So if that is what we receive, which we'll find out probably in another week or so, then we have a lot of infrastructure in place already to be able to support that. Now, to pivot to the other side of it related to defining how to get those folks, as you identified, who aren't in hospitals or aren't necessarily in the nursing homes, how to get them access to it. So this is one of the areas that we're awaiting further guidance from the state on, but we anticipate that that will be at least a temporary role until the vaccine becomes more readily available for private providers, but a temporary role that health departments will be able to fill. So we're looking to create closed pods to be able to distribute the vaccine to those groups. And then again, as it becomes more readily available to private providers and the supply goes up, we would be more likely to have some of the open pod type distributions that we might be accustomed to during an epidemic.
Mr. Chairman, may I have one more question?
Brief question, please.
Thank
Yes.
you. And if you can't answer it, that's fine. I'm very concerned that we're going through Immunet and folks have to sign up for that if they're trying to distribute to some of those groups. The VA, that group, people who are getting for that's not lined up with Immunet. And I'm concerned, do you see a problem tracking the residents in Montgomery County, since the veterans who will be supplied are not registered with the Immunet system? And do we need to do something, or ask the Department of Health to do something to make sure that we have those accurate records?
That's, again, an excellent question that we're continuing to think through. I do know one of the mitigating features that I think MDH has put in is the notion of kind of a vaccine card that, young folks have in terms of, having records and documentation of their vaccines, where there may be situations where systems don't talk, particularly in the short term, to be able to expedite and make sure someone gets the vaccine. Let's say they get one from the VA and then they want to come and try to get that vaccine somewhere else. So I know that's been some of the early discussions as a way around that, given the short time frame. But certainly, yeah, we all continue to think through those strategies, and there's no definitive answer or fix to it at the moment.
Okay. Thank you, Dr. Gales. I see no other questions.
I have one question.
Certainly, Delegate Peña-Melnick.
Thank you, Mr. Chairman, I appreciate it. And thank you, Dr. Gale. Thank you for coming. Can you tell me, regarding the Black and Brown community that have really taken the brunt of COVID-19, right? We have been affected the most. The data is so clear, undisputable. What do you recommend that we should do in those communities? You heard the plan for the department today, but I feel that it's missing something. What are you doing in your jurisdiction, or what can you tell us that we can do?
Well, I think honestly, to answer that, it may be a little bit less about the vaccine and some other things. For example, so I obviously got to, increase messaging related to vaccination and increasing the percentage of folks vaccinated to maximize coverage. But we know that it's going to take some time for the vaccine to reach to the point where it's open to the broader community. And that is a window where we could still see significant levels of transmission, thereby significantly impacting communities. And so one of the things that we've looked at in our county is trying to assess, we know that working outside of the home is a big risk factor for coming into contact with COVID-19. And we also know that disproportionately Black and Brown residents of Montgomery County are essential workers in those spaces that put them at higher risk. So what we've tried to do in our recommendations and restrictions that we put forward is to have tighter enforcement, whether across different types of employers, making sure that they have the adequate provisions in place for workers to stay safe. I think this is an area where, and again, I will say this, I'm a public health person, I'm not an economist, but I think where economic relief is significant, not only in terms of the form of providing economic support for workers, but most often a lot of those employees who fit into those jobs don't have access to telework. They don't have access to paid leave, sick leave, or family leave to take care of their families. And so they're more likely balancing that need for economic support and relief to take care of their families with health. And it's unfortunate that they're put in that situation. So I think this is an opportunity where, whether it's at a federal or state level, that economic support would tremendously help offset some of those risks of exposure having to come to work, as well as being able to keep them protected should they develop symptoms and have COVID, being able to prevent them from potentially spreading it to other members in their family or within their workforce.
Thank you so much. I appreciate you. Thank you, Mr. Chairman.
Thank you, Doctor. That will conclude the hearing on.
Sorry, Delegate Lewis Young, I believe also has.
Oh, I'm sorry. Please, Delegate Lewis Young.
Thank you. My question deals with the immunity issue. If we don't know how long immunity lasts, how can we plan for herd immunity and the number of vaccinations that will be needed to achieve that?
That is another excellent question, which we are hoping to get more guidance and information from the ACIP, as well as the hearing. Once these vaccines are approved, we'll get more clarification on that. Because unfortunately, we have the same question that you had in terms of waiting to see the information. And that speaks to a lot of the challenge, which gets back to our efforts to try to get as many people vaccinated as possible. Those are natural questions that people are going to have. And as we get more information, this is a challenge with an expedited process. Naturally, people are going to have those questions and be curious before they get the vaccine. And the hope is that as these hearings move forward, we'll be provided more clear guidance around that. So we'll be able to answer those questions proactively and alleviate any anxiety related to getting vaccinated. But great question. Yeah.
Thank you.
Okay. Thank you. My thanks to the committee members and to our guests from Appropriations. I now turn the gavel over to Vice Chair Peña-Melnick.
Thank you, Mr. Chairman, and thank you everyone for your patience. This is the last panel, so we're almost done. So hang in there. Thank you so much for your flexibility. Next, we have an update from the Maryland Medical Cannabis Commission, and we have Mr. Will Tilburg, who's the Executive Director of the Maryland Medical Cannabis Commission, and he's going to present and tell us about all the licenses and where we are. So welcome, and go ahead. You can get started.
Good afternoon, Madam Chair, members of the committee, Chair Rosenberg, and other members that are remaining on. I know it's been a long afternoon already. For the record, Will Tilburg, Executive Director for the MMCC. I am joined today by Ms. Taylor Caskey, who is our Director of Policy. She will be available for any questions, to assist with any questions when the presentation is completed. I want to first thank you for the opportunity today. I think these briefings are very important for us at the Commission to have a conversation, particularly with HGO and particularly with the Public Health and Minorities and Minority Health Disparities Subcommittee, because this is the only committee in either the House or Senate and subcommittee that gets all of the medical cannabis bills. So you all for the General Assembly are the subject matter experts. Everything that relates to this program comes to you. And so I'm always incredibly grateful for the opportunity to discuss the program and provide updates. It also, the briefing comes once a year, and so it provides a good opportunity to take stock of the health of the program, the growth of the program, where we are. Last year at this time, on a personal note, was 2 weeks into my tenure. And so now it is also a 1 year look of sort of how things have gone. And so today, I want to focus really on three things. That program update, looking at some of the health metrics that we identify for the program itself, patients, providers, these types of things. Two, identifying the COVID-19 measures that we implemented as part of the medical cannabis program. And then three, our commission activities throughout the year with a focus on activities related to implementing the legislation that you all passed in 2020. First, though, because we do have additional members on who aren't on HGO or this subcommittee and may not know as much about the program, just one quick slide on our background. Next slide, please. So first, we are an independent commission within the MDH. So in addition to everything you heard from the previous panels about MDH and what they're working on, they also provide procurement, IT, and other types of support for the Medical Cannabis Commission, the other 20-odd health regulatory boards and commissions in the state. We're incredibly appreciative of that support. We wouldn't be able to function without them. Our mission that you all put into statute is to provide a safe, effective, and consumer-friendly medical cannabis program for qualifying patients. And that's what we strive to achieve every day. What is the commission itself? It is a body of 13 volunteers. 9 of those volunteers are appointed by the governor. 3 are selected by the governor from a list provided by the Senate President and Speaker of the House. And 1 is the Secretary of Health or their designee, currently Dr. Jinlene Chan. Below the volunteer commissioners, we have a full-time staff, of which I am one, that oversees the day-to-day activities of the program within the state. The program itself and commission activities are 100% specially funded. No state dollars go to the Medical Cannabis Commission. Primarily license fees, 75% of our budget comes from growers, fees assigned to growers, processors, and dispensaries in the state. Our FY 2021 budget was just over 10 million, which was pretty flat from the previous year of 2020. In terms of what we do, the major program functions are listed here: licensing and regulating the growers, processors, dispensaries, the independent testing labs, and the ancillary support businesses, the secure transport companies, delivery companies, waste disposal companies, and the like. The registration and regulation of patients, caregivers, and certifying providers, that is processing those applications, answering hundreds of phone calls a day, addressing questions from these stakeholder groups and the like. Enforcement of the statutes that you all pass, regulating the program, and the regulations that we adopt to implement those statutes to ensure the safety of the products and safety for patients. And then lastly, and critical but often not discussed, is the public education. This is a new program. There's still a stigma attached to cannabis. And so a huge part of our role is educating stakeholders, educating the public, educating you all on this committee and in the General Assembly on the program, on the commission, and on medical cannabis. Next slide, please. So the program update will look at 3 different metrics: patients, where we are for this year compared to previous years, same for providers, and then look at the growth of the program itself with the businesses. Next slide, please. In terms of patients, there continues to be immense growth year over year. So we've seen, with not a full year yet in 2020, a 30% increase in the number of patients. We're now over 120,000. That's nearly 30,000 more than were registered at this time last year. In addition, the application volume, so that is the number of Marylanders that are submitting applications each day, is somewhere between 150 and 200. This is down slightly from past years where we were between 200 and 300, but still a very high volume that demonstrates continued growth. An issue that's come up on this committee in the past has been application processing time. Due to technical issues in the 2019 time range, the application processing time had ballooned up to more than 30 days. Since that time, we have staffed up significantly and made some streamlining efforts to the IT system, and have been able to maintain processing times more in the range of 10 days from when a patient submits to when they're registered. In addition, the providers and caregivers are processed same day because it's a significantly smaller volume. In addition, the pending applications, which had ballooned during that period where we had 30-day processing time, has been reduced from 10,000 to 1,100. When I spoke with you all last year, it was down from 10,000 to about 4,000. We had hoped for it to be at zero. By this point, the pandemic did alter our operations, where our call center and quality assurance folks that process the applications are almost exclusively working remotely. And it took some time to get adjusted to that with laptops and internet and the like. So there was a bit of an adjustment period. We are back on track now with the processing times and continue to reduce the backlog of applications. In addition, we have established an in-house call center. Previously, we had a third-party contractor performing these services. The benefit of the in-house call center is it's saving the state money, saving the commission money, and also the patients and providers are able to directly connect with subject matter experts, as opposed to what was essentially a call service that was taking messages and transferring to us. On average, we're able to address questions and resolve calls within 3 minutes. Next slide, please. Turning to providers, this is critical to the previous slide, which is patients. In order for individuals to become patients, they need to see and obtain medical cannabis. They need to see a provider within the state. We've continued to work on outreach to the boards to increase these numbers. You all in the General Assembly have assisted by expanding the number of professions that can qualify to certify folks for medical cannabis. And so just in the past couple of months, we for the first time have surpassed 2,000 providers in the state. With the addition of physician's assistants this past year, there's especially been a expansion in rural areas of the state where more individuals are now able to get certified. Next slide, please. The final piece of the program update is looking at what I've called here economic metrics. So this is retail sales, wholesale sales, pounds cultivated, and then the average cost. So in terms of retail dispensary sales, there was significant growth again. Here on this chart, you can see 2017, which was only 1 month. The program started in December of 2017. 2018, we had total sales of 111 million, in excess of 255 million in 2019. And with still a month left, we're at 423 million here in December. These numbers are as of December 3rd. So this is on track for an excess of 450 million. So significant growth again. It is slowing, where we saw a more than doubling of the retail sales from 2018 to 2019. That has slowed, but again, still significant growth. The same sort of reflection for wholesale revenue. So that is a combination of the growers and processors who cultivate the product and then process it into a variety of products, tinctures, salves, bombs, vapes, and the like. Pounds cultivated also continues to grow from 2019 to 2020, but that growth has somewhat slowed. Again, it's not a doubling that we saw in the previous year. Most importantly, and this is a question that this committee has asked in the past, is this increase due to increased costs? Is the cost of medical cannabis going up in the state? Is that why there's more revenue for the dispensaries and for others? And the answer is no. And the other question is, where does Maryland compare to the illicit market and to other states that have either medical or adult use programs? And so that's what's included here on this slide. The average cost per gram of medical cannabis is $10.88. It has remained relatively stagnant over the last 12 months or so. Previous to that, there were some ups and downs. In comparison, the Maryland illicit market is valued at more than $14. Where did this figure come from? Certainly, I don't know personally the value of the Maryland illicit market. We have hired a third-party consultant to perform a market analysis on the state of this program. and a projection for the next 5 years. And in that, they assessed the illicit market through a number of internet websites that track these sort of figures. And they also compared it to statistics in other states. So the average across other jurisdictions is $13.71. What's the takeaway? Of the 25 states that our consultant looked at, Maryland was the 5th or 6th lowest cost. And the cost is lower than the illicit market. Why is that important? If the cost is lower than the illicit market, individuals are more likely to join the medical cannabis program as opposed to using products from the illicit market, which do not go through laboratory testing or are otherwise regulated. Next slide, please. Turning to COVID-19 measures, obviously, the pandemic has impacted all of us, all the state agencies and all the programs within the state. I very briefly want to touch upon how it impacted the medical cannabis program and the measures that the commission took in an attempt to protect patients and employees of particularly dispensaries, but of all of the licensees and registrants. Next slide, please. As you may be aware, Governor Hogan, when the stay-at-home order was put in place, had designated medical cannabis licensees as essential businesses. So they were able to stay open throughout the pandemic. We thought that made it even more important that we implemented all precautions necessary to protect patients who are vulnerable, primarily vulnerable populations, older, infirm. And so the way that the program is set up for safety and security reasons, these folks have to come into the dispensary, meet face-to-face with someone and go into the service floor in order to access their medical cannabis. That leads to a lot of interactions and being around a lot of other people. And so we tried to take steps to limit the interactions between employees and patients, and generally the number of individuals who would be within dispensaries. So we eliminated receipt signature requirements, required face coverings and social distancing in advance of the executive order requiring the same, authorized contactless on-site delivery. So instead of having to go into the building, allowing for dispensary agents to come out to the parking lot and conduct the transaction there, expand delivery options and the number of businesses that can provide delivery, authorize telehealth for written certifications to obtain medical cannabis, to limit the number of visits to doctors' offices for patients, authorize drive-through dispensing. Many of our dispensaries were put in places in buildings that were formerly banks or food establishments. And so they had drive-through options that we had not previously allowed them to authorize for security reasons, I should say. And with certain security protocols met, we have authorized that throughout the pandemic as a way to limit the interactions between patients and employees. In addition, for our staff, we have initiated virtual compliance inspections for many of the routine day-to-day inspections that we perform. Next slide, please. Turning to the third topic today, which is MMCC activities. I'll look first at the enacted legislation that this committee, the subcommittee, and the General Assembly passed last year, and then what we've done to implement it. Next slide, please. So in 2020, there were 41 cannabis-related bills. That is actually down from the previous years. It was a bit of a breather for us at the commission. 26 of those bills were introduced within the House. Of those, the three major pieces that passed here with tremendous bipartisan support are listed. So first, we have House Bill 378, which was for certifying providers. It expanded the professions that qualify to be a certifying provider. That is an individual who can certify a Marylander to obtain medical cannabis, to include physician's assistants that have a delegation agreement with a physician who is also a certifying provider. Second, House Bill 617. For those on the committee, you likely remember this lengthy committee hearing on cannabis use in schools. So expanding the ability, allowing the ability for minor patients to access their medical cannabis on school grounds, requiring MMCC to work with MSD and others in the state to develop guidelines overseeing that, and allowing for the expansion of caregivers. That is, the individuals who administer at home and possess the cannabis for the minor patients, expanding the number that can be had. So in case mom and dad aren't able to go to the school grounds to administer, an aunt or an uncle or a family friend would be able to, if identified and designated by the parent or guardian. And lastly, revisions to the Compassionate Use Fund in HB 870 which requires the commission to establish a compassionate use fund for Medicaid enrollees and veterans in the VA healthcare system to access reduced cost medical cannabis within the state. So that's what passed. On the next slide, we'll see what the commission has done to implement those measures. Next slide, please. Thank you. So physician's assistants, the law took effect on October 1st. I'm proud to say on October 1st, anyone that was a physician's assistant in the state was able to apply through our online system and have same day approval if they are licensed and if they are in good standing with the Board of Physicians, they were automatically authorized to certify. So that was immediate. Second, caregivers for minor patients. Delegate Schlegel had asked a question at the hearing about, well, this seems simple. Isn't this something the commission could do immediately, just expanding the number of caregivers that a minor patient has? And I said, absolutely, that does seem simple. And then I went to my staff, the IT staff, and they screamed at me because it was absolutely not simple. But we were able to implement it on June 1st when the law took effect, that minor patients were authorized to have more than 2 caregivers, expanded to 4. Our IT system authorized that. So on day 1, on June 1st, parents were able to go in and designate up to 2 additional adults. So the day that you guys authorized it, we had it ready to go. Medical cannabis and schools guidelines. Again, if you can recall these discussions, there was a lot of debate about when these guidelines could be developed. And this is before the pandemic had really ramped up. And a lot of the folks at the table with me said, it can't possibly be done by December 1st. We need May or June the following year. The compromise of sorts was December 31st of this year. And at this juncture, the guidelines have been developed. They've been approved by MMCC. They've been approved by Office Attorney General for legal sufficiency. And I anticipate this week or next to have final approval from MSDE and for them to be public. This was an incredible undertaking by a lot of staff, a lot of agencies, MMCC, MSDE, MDH, local school jurisdictions, nurses, a lot of cooks in the kitchen, and they did a fantastic job putting this together on a tough timeline during a pandemic. So I especially want to thank Taylor, who's with me today, and Christy Megna, who is our senior regulatory analyst, who worked very hard on that. Legislative report. Out of that same schools bill, we were required to submit to you all by December 31st, whether based on the schools bill, any changes need to be made to state law for the nurses or others. That report has been finalized in draft form and is sitting on my desk for my approval before submission to you all, which will occur in advance of December 31st. Lastly, the Compassionate Use Fund. We worked with MDH Office of Finance. We set up the fund. That also is more difficult than one would think. And I'm proud to say that effective July 1st, the commission allocated up to 25% of the fees collected from patient registration. So the folks that are actually going to benefit from it, 25% of the fees that we collect for signing up and administering the program are going to go to this. To date, so from July 1st to through November, that's in excess of $400,000 that's going over. Now, this was not how the fund was to be funded. The fund is to be funded by fees assessed to the growers, processors, and dispensaries. They are on board. They supported the legislation. We're working with them on a regulatory proposal. But in addition to that, the commission wanted to use our funds because this is really important. And we've done that and we'll continue to do that. And I'm very proud of the decision that the commissioners made in that regard. Next slide, please. Okay, next slide, please. So the last 2 things that we have to talk about, license awards and then other activities. When I spoke with you all last year, we were in a very different place. We had solicited 2019 applications. There have been claims of bias, undue influence. There were certain charges pending, related to legislators and lobbyists, and a significant amount of doubt about the program and this process. At that time, I said at the commission, we had requested an independent investigator to come on board to evaluate the work that the commission did, the work that Morgan State, our chosen reviewer, had undertaken, and to provide back results. We were also going to do a second investigation into verifying ownership and control. Entities, applicants received points related to claims that they were majority owned by disadvantaged applicants, so having a certain personal net worth, and individuals who were African-American, Native American women Hispanic, or Asian. And so we were going to confirm those claims. It took a while, and that's because this was a very thorough investigation, 2 investigations. We released publicly the Zuckerman-Spader report, which indicated that there was no evidence of undue influence or bias in the 2019 application process. That allowed the commission to go forward and review the results of the financial analysis to ensure that the folks that applied saying that they owned these applicants actually did. And October 1st, MMCC awarded 3 grower license pre-approvals and 8 processor license pre-approvals. The breakdown of those awardees is listed here. So if we go back to House Bill 2, the mandate from the General Assembly, from you all via emergency legislation, was to address the needs of small minority and women business owners and entrepreneurs interested in being licensed within the medical cannabis program. And of the 11 awards, 11 went to majority disadvantaged ownership. 9 out of the 11 majority African-American or Black ownership. 5 out of the 11 have majority women ownership. If you were to look at any state in the country, and we have through our consultant that did this market study, market analysis for us, these results have not been achieved anywhere else in the country. This breakdown of diversity has not occurred in any other state, even when you have jurisdictions on the West Coast that are uncapped, that anyone seemingly can sign up. The percentage of businesses owned and ownership percentages does not come close to replicating what the result of this application round was. It took a long time. There was a lot of work that went into it. We've had a lot of discussions about it, I know, but the evidence here is clear. The General Assembly said, we want greater diversity, and that is what has been achieved through this application process, as you see here. Next slide, please. So if you can believe it or not, there are other things that we do at the commission that's not license awards and not related to just legislation that you all pass for us. I'll tick through these very quickly. I know I've been long today, but I'm incredibly proud of the hard work that my team has put in over the past year. First, we're a founding member of the Cannabis Regulators Association. As you know, cannabis is federally legal. There's no federal oversight. Informally, Maryland and other states have been getting together for the last few years to talk about best practices. How do we do this? How do we navigate a world without federal oversight and with a lack of research and other evidence? And formally, this group created the Cannabis Regulators Association last month to provide, it is nonpartisan, it is just to provide best practices and evidence based on the regulators operating this space over the last 5, 10, 15 years, depending on your jurisdiction. I have found these resources invaluable. I look forward to being able to share these resources with you all as you consider important bills this session. Second, migration to centralized IT enterprise system. When the commission was created in 2014, 2015, it was sort of like a major league expansion draft. MDH gave us some things. Do It gave us some things. There was very little of the commission's own because the program had to be put together very quickly. We now, in the next month, will have our own IT system. We're moving over and incorporating with One Stop. So all of our licensing, all of our registration will go through the central hub that most state agencies use in the state. It's going to streamline it for patients, going to streamline it for providers, streamline it for licensees and others. That will also speed up our application times even further. 3, ID card fee waiver. We talked about the Compassionate Use Fund. In addition, the commission has waived that $50 registration fee for Medicaid enrollees and veterans enrolled in the VA healthcare system. That took effect on September 1st. Rollout of the edible cannabis program. You all passed a bill authorizing that. We developed the regulations. With the pandemic, the Department of Health hit pause on regulations. So there were several months where regulations weren't going forward from the Department of Health. That has ended. So those went into draft last month, and we anticipate the edible cannabis regulations being finalized in January. We created our first annual report. I'm happy to, I sent that to committee staff. It has a lot more detail than I provided today on all the work that we're doing. I mentioned the market study. I'll also be sharing that. It's 60 pages, so I'll be sharing an executive summary as well as to the impact that legalization would have on the state, which is something we said to the committee last year that we would look into. And the impact that legalization would have on a medical cannabis program and medical cannabis patients. We went through a 7-month process updating our laboratory testing requirements, doing workshops, public meetings, soliciting public input, et cetera. Those are being finalized likely next week. And then we're also developing our own reference laboratory. Again, because it's Schedule 1, labs in Maryland, there's a lot of state labs, they can't touch cannabis. And so we have been dependent on independent testing labs, which do a great job, but for compliance and other reasons, it's important that we have our own reference laboratory. And finally, we're in the position where we can move forward with that. And when we're having this conversation, hopefully next year, I'll be able to talk about that being off the ground. So next slide, that's it. I know I went a little longer than staff I think had said I should, but again, I think we've done a lot at the commission over this year. I wanted to share some of these updates. And as always, I'm happy to answer any questions you may have.
We thank you so much. And what's new, Mr. Tilburg, since he was last with us committee, is that he was used to be a family of 2. Now he's a family of 4. He has had a set of twin boys. They're 6-month-old, and welcome to the twin, club. I have a question, my pleasure, from Delegate Lewis. Delegate Lewis.
Thank you, Madam Chair.
My pleasure.
It's great to be with everyone. Thank you, Mr. Tilburg, for your presentation. Hopefully you can hear me okay. So my question is this: what do we know about the use of medical cannabis in behavioral and mental health telemedicine?
I'm not sure I understand the full scope of the question. Would you?
I was trying to be short. That's a slippery slope. Either too long or too. Anyway, I guess what I'm curious about is, having expanded the group of providers who can prescribe medical cannabis, now PAs can do so, and given that we've expanded telemedicine, and although it's imperfect, we're also trying to broaden access to behavioral mental health via telemedicine. I was just wondering if you might know or know how to determine whether medical cannabis is being prescribed in behavioral health settings via telemedicine. And if that's too tough a question, I totally get it, but it would be interesting, I think, for us to learn more about that.
Yeah, no, absolutely. And I'll circle back with staff to try and provide a more complete answer, but I'll give it a college try now. To be frank, we were hesitant to move forward with the telehealth, and as cannabis in Schedule 1, it was a little different from the other, the legislation that you all passed for other things because of concerns similar to what you've raised today. But the program, as it's been set up, puts everything on the medical professionals. So there are states that rigidly prescribe what a qualifying condition is in order to obtain medical cannabis. Maryland is not one of those states. We have a list of suggested conditions that be approved, but in addition, it's the best in the professional judgment of the provider. If the benefits outweigh the risks, and there's been attempts at alternative treatment and they haven't been effective. So for something like opioid use disorder, we've had discussions in the past about expressly adding that as a qualifying condition. And we were actually at the commission required to develop a report on that. And the evidence at the time was there's no evidence to clinical scientific evidence to support this. That's actually changed a little bit over the last 2 years. Pennsylvania, New Jersey, New York have authorized it. And so they've started to gather data. There's a growing but imperfect body of evidence that it may be helpful in certain circumstances for treating withdrawal symptoms and similar. And so it's something that we're certainly monitoring at the commission, but within the state, you don't need an express authorization as a provider to allow that. There's something in statute. If in their judgment this is good to treat that, then they can do that. And we are aware of that happening. When a provider registers with us, they have to list the things that they'll certify for, and they also have to, when they give certifications, identify what the condition is. And so I can go back and look and pull and see a number if there's certain conditions and things that you're specifically interested in. It's an area that our Research and Education Committee is very focused on. We want to see what data is there, what do we have now we can put together. So it's an open question we've had. I'm happy to continue the discussion. I don't know if I answered your question at all, but that's where I thought you may be going with it.
Yeah, just to get a sense of what we know so far. I appreciate your answer. Thank you. Thank you, Madam Chair.
My pleasure. We have next Delegate Hill.
Right. Thank you. First of all, thank you for being here today, and thank you, Madam Chair, for allowing me to ask questions. And congratulations to you and the Commission for this boatload of work that you guys have done during a difficult time. You all made a lot of changes to make sure that the patients could get their medical cannabis during this time. So the first question is, do you have a sense of how many of these changes you will be recommending become long-term, or you'll be making long-term? And then the second question is that we've heard from some of the providers or some of the prescribers that there's been some laxity in terms of the dispensaries actually referring customers to different prescribers, which is not what we wanted in our medical market. There seems to be a sort of a merging of a medical cannabis market to just being a availability street market kind of thing, a recreational market, because of some of those lines being blurred. And if I'm not being clear, I'll have to come back to you offline with that question. But so really it's about the changes we've had to make to make sure the patients and are there some of the things that are a little bit too lax that need to be tightened up on? Thank you.
Yeah, thank you. Thank you for referencing the COVID-19 measures, because what I should have said at the time was there were virtually no incidents with any of those things. So the on-site, the curbside, pickup delivery, the drive-throughs, which had, and understandably so, I think, given folks pause at the outset of creating a program, Schedule I substance, you hear about crime and other things in other jurisdictions, there have been no incidents. And so we held a public meeting this summer to say, hey, stakeholders, how is it going? Is this something that's working or not? Let's provide feedback. And overwhelmingly from all stakeholder groups, it was this is a good thing for particularly those that are maybe at a heightened risk for having serious issues with COVID, or have limited access for ability to move for some reason or other. That these were important changes. So based off of that July meeting, the Commission authorized staff to develop 3 permanent proposals: on-site or curbside delivery, drive-through, and expanded companies and options for delivery. So all 3 of those things are either in the formal pipeline for regulatory change or have been developed and are waiting to get public comment with the Commission. So a bunch of these things have been really effective, and we're making them permanent. To your second question about the laxity, what it triggered in my mind, and maybe this is what they're talking about or not, is there are allegations of certain fly-by-night providers that will certify anyone, right? And so this is something that's existed, claims have existed and concerns from the outset of the program. And one of the issues is the Commission is not the primary regulator of any of these medical professionals. We cannot really take important action against them. That belongs to the licensing board. So one of the things that I prioritize is making sure that we have better communication with licensing boards if we have a problematic provider. But we don't have subpoena power, way to get records for these folks. So it's difficult for us to identify. A lot of times it has to be a partnership with the boards to determine, are they actually, for lack of a better word, a pill mill or something or not. But if folks have concerns, if people you talk to have concerns, we investigate any complaint. And, we can look at track record, how many people are being certified, and, there's certain patterns that may raise concerns to then, probably conduct a joint investigation with one of the boards into that provider. It's not acceptable to me that's occurring, if it's occurring, but we need to be notified of it in order to take action. So I would plead with you and whoever you're talking to, if they have concerns about a particular provider or a group, that they notify me so we can take steps.
All right, thank you. Madam Chair, may I ask one other question? Thank you.
Sure.
You're talking about the edibles ready to roll out. I'm just curious, we've talked about this for the last couple of years. Are there any restrictions or any disclosure requirements about herbicides that are used on these edible plants going into relatively sick people?
There's not. It's something that as you're aware, the General Assembly has considered in past years adopting a statute. You've sponsored some of that legislation, and it hasn't been enacted. If a bill was passed, we would certainly add it to. With edibles, I will say that there is expanded packaging and labeling requirements for because it's now containing food products and food ingredients, everything that's within it, any potential allergens, specific information on the concentrations, bolder warnings that there's THC in it for children, child-resistant packaging, caps on the amount of THC for these packages. The concern of this committee and General Assembly for edibles was primarily children, accidental ingestions, and overconsumption by novices. And we took that very seriously. And so that's why we did put in a cap on the amount of THC that can go into those specific edible products, whereas there are not caps on tinctures and tablets and other things. They have to be in child-resistant packaging. They have to have our big Maryland THC, red bold warning on it and those things. So we think that we've taken through the regulations a lot of common sense steps to prevent issues that can result with edible cannabis products. And I'm happy to discuss any of those with you more in depth. And I can also share the new packaging and labeling. I know it's not going to get at the herbicide stuff, but you can see what is covered.
Thank you. Any other questions? I have one. It's a final question. Did you advertise for the third-party consultant?
Yes. So it was both of the procurements for the two contractors were emergency procurements, which typically are not competitively bid. But because this is such a high-profile issue, a lot of folks were interested in it. We wanted to be as transparent as possible, and so we did go through the competitive procurement process. We did receive several great bids, and ultimately anyone was able to apply that was interested in it.
Thank you so much for your time. I don't see any other questions in the chat. I really thank you for your time and thank you for your work. Mr. Tilburg, you're doing an amazing job. You're very accessible whenever we have a bill. You come to the office, you work with everyone involved. And on behalf of my chair and the committee, we thank you for your work. We really appreciate it.
Thank you. That means a lot to hear that. Thank you.
You deserve it. As of now, members of the committee, the Health and Government Operations Committee and all HGO subcommittees have reached the end of our interim briefing schedule. You can take a deep breath and stretch. So for updates related to our work, please continue to check the Maryland General Assembly website and be on the lookout for new information from the committee staff. Check your emails and please make sure that you reply. Until then, we look forward to seeing you when the 2021 legislative session convenes on Wednesday, January 13th. It is going to be very different, so we just ask that you be patient with us and be flexible, and we welcome your ideas, okay? We're going to do it together. I know it's going to work out. Have a good day. Thank you, staff, for helping us run this meeting, and my co-chair, thank you so much for the way you ran the meeting. Have a happy and healthy holiday season and an amazing new year. Wear your mask, stay safe, please. I want to see all of you. Have a blessed day. Thank you very much. Mr. Co-Chair, would you like to say something?
You've said wonderful things about everybody, including me. It goes for you. We have quite a workload in front of us as a committee come these issues and many other issues come January, and we look forward to working together with all involved to achieve our goals. Thank you.
Thank you. Have a blessed day, everyone.